Good morning, ladies and gentlemen. Welcome to the Burke County Board of Commissioners recess meeting for Friday, February the 14th, 2025. Happy Valentine's Day to everybody. Thank you for being here. I'll remind you at this time to silence your mobile devices. If you got telephones and things that make noise, please take care of those at this time. Madam Clerk, I'll note that all commissioners are present, along with a number of staff. The county manager is to my left. Would remind you as you speak today, over here will be lectern for you to speak from this morning, and would remind you to be sure to turn the microphone on so we can hear you and get a good recording and be able to see our meeting and hear our meeting on YouTube as well. All right, gentlemen, you have in front of you and have had for a few days the agenda for this meeting. I would entertain a motion to approve the agenda.
Make a motion.
Thank you, Mr. Stroud. All those in favor signify by the uplifted hand. That is all of us. All right. This brings us to item number 3, items for discussion. Today's meeting is primarily aligned with our opioid settlement funds and strategies as we move forward, and an update on where we are. So that will bring us right into item A, opioid settlement background and North Carolina memorandum details. Our manager, Mr. Epley, is going to present that information. We'll hear him first. Mr. Epley.
Thank you, Mr. Chairman. Appreciate the opportunity to be here this morning. I think I'm very excited about some of the information we're going to cover. I think that, at least to my understanding, this is one of the first times that our Board of Commissioners as a unit have convened to talk about, something that's a critical area of public policy and something that Burke County, along with all 100 counties in North Carolina, are trying to work on, something that we know that is critically important to our community. And so I think, as you said, the purpose of today's work session is to largely review what we've been able to accomplish over the last few years since we've been given this responsibility of funding through some very large settlements through our Attorney General's office and really national litigation, as well as the systems that we may have in place. Because I think we're at a unique spot, and that's really what I wanted to tee up this morning before some more of our experts. We have Nitty from the County Commissioners Association, which is the director and lead for a technical assistance team, and really the subject matter experts around the parameters of these settlement dollars in North Carolina. And then we also have a community education group, which are here to really talk to us about some of the information they've been seeing. They're a contracted consulting firm that's been working on a strategic planning process for the county over the last few years, and then as well as our local health director and the team that's been kind of leading the local grassroots strategies here in Burke County, and kind of evaluating where we are, making sure that our systems, that we're all, I guess, in tune and we're all on the same page with our goals. Then lastly, kind of set the systems in place to be efficient and effective, because I think we're approaching this intersection of really a combination of several important pieces of data that I'll talk about as I get a little bit more into this kickoff. One thing that I would say is we've really tried to be hyper-focused over the last 2 years about identifying a common purpose around Burke County and centering all of our work around what it is that we're trying to accomplish. We think that helps measure our success. And at its most simplest form, Burke County government is here to improve lives. We try to accomplish all things that we do through a shared group of values that dictate our behavior. Here's just a quick outline of what I would just cover as far as what we're going to try to accomplish today. And then, I think that as we leave, if we've have clear direction on how we're going to measure success and where we're going, that'll be the evidence of a successful working session. I would remind you that the Board of Commissioners does have a strategic plan that they've been operating under now for the last couple of years. We meet annually to review, evaluate, measure success, and set new priorities and new areas of policy. Under our public safety focus area, The effective use of opioid settlement dollars is something that the Board of Commissioners have continued to prioritize. And really, we began to talk about three really higher arching goals. The first one is to try to evaluate ways to reduce the onset of new users. We think that that's important. Evaluating pathways to recovery for those folks who are ready to be in recovery, making sure that we have infrastructure in place to facilitate that. And ultimately, the goal, I think, as we all know, is to reduce the number of people that are dying. When we look at opioid deaths per capita, emergency room visits per capita, we know that Burke County's struggled in some of those areas. We've had indicators that suggest that we are kind of outliers around the state, no matter how you really measure our intensity. And so again, we've been given this opportunity through a significant amount of resources. It's roughly $24.5 million, and this was before the most recent settlement with the Saxler family and some of the other groups. I think this is going to grow between $2.5 and $3 million more. All of those details aren't 100% ironed out yet, but this is the baseline amount. It'll be a little bit more, paid over 18 years, and you can see the kind of the chart on the top. It's kind of a declining, diminishing return, if you will, over time, over that 18 years. But we've been given a tremendous resource and an opportunity to put that to work to try to make a difference. Those resources have to be managed through this memorandum of understanding. That's dictated through, the Attorney General's office and the Department of Justice. Inside that MOA, and what Nitty's and her team are going to talk more about in detail, is the parameters for facilitation. What are the allowable costs? What are the compliance requirements? What are the industry best practices? They break down into what I would call option A and option B. That's what they're referred to in the MOA. The short answer is the option A options are options that are evidence-based strategies that are largely approved for all 100 counties, meaning on day one you could have started doing those things. Option B has a process to, quote, unlock, and it's a pretty substantial process, takes some time, but it gives you a higher level of flexibility in what the MOA calls a longer list that includes things that some communities have decided to really highlight, prioritize, and work towards. Here in Burke County, of the option A strategies, option B is not yet being utilized. I think that's been something that's been talked about, but not quite there yet. Under the option A strategies, we have implemented two. We have started the collaborative strategic planning process. CEG, who's with us today, has been working on that, as well as done a significant amount of naloxone distribution and harm reduction. A couple things that I would just share to tee up the day from a data perspective. This is a heat map, and I think Scott back there is going to follow this link, but this is an interactive ArcGIS map that we've been building. We set up a system 2 years ago in our 911 system so that every call that comes in that has a symptom during the diagnostics of the call that may be associated with an overdose situation, we flag it. Every overdose has an EMS dispatch. So the flag comes from the incoming call to track the address, the type of, the person, the demographic, and then when EMS is deployed, they either validate or don't. And for those that, when they arrive on scene, it isn't truly an overdose, we kind of cull that information. The rest of those calls are put into this heat map, and our goal over time is to collect enough information so that we can do predictive analytics about where these overdoses may be happening before they happen, and maybe deploy preventative resources to those areas. I've given our board members a chart, and what's in front of you is the number of addresses with duplicates. We know that we have frequent flyers. We have some addresses that we've been to 10, 11, 12 times in the last 2 years. And oftentimes that's areas of congregate living. Oftentimes that's multifamily housing. So again, I think it's just an effort to try to collect data so that when we have PIDS report, when we have some of the resources that we can deploy in a preventative way, that we have, we can do that. So if you drill down on these, we can tell what date we were there, how many times we've been there, who the victim was, all of those type things. Okay, thanks, Scott. One thing that I would point out is this hottest spot is the prison, but the vast majority of, which I think we've been there 34 times, the vast majority of these, as you can see, kind of follow that I-40 corridor. So this is the total number of calls over that 2-year period, going from January 22 to November 24. The trend is slightly up if you follow the trend line, but I think it's close enough to say, even though there's months of higher and months lower, it's pretty well stable, the number of calls coming into 911 that have some symptom of overdose. So I think the number of overdoses, although volatile, have a slight trend upward over the last 2 years. What do we know about those folks? Well, we know that here, this blue bar is January 22 through July of 23. That's the 18-month measurement period. And then we measure August of 23 through 24 in the orange. And the peak time is in the afternoon between 2 and 8, so that we know most of our overdoses are happening in the afternoon. We also know, when we break it down by age and gender, that the vast majority of our overdoses are men between the ages of 26 and 45. So again, there's a connection and a tie to 26 to 45-year-old males in the afternoon from 2 to 8, and we're piecing together the ArcGIS data about where they are. So maybe we can start to hone in a preventative way on who those folks are. Even though I think the number of overdose calls coming into 911, and we know that doesn't encapsulate all overdoses. Some people do not call 911, right? We don't have that data. That data is absent from our set. For the calls that we do have coming in, I think that many of the things that we've been working on are working. And that should be celebrated and recognized. Although this is measurement of deaths over the last 3 years, overdose deaths, and even though the trend is slightly upward for total overdose volume in the county, the data for deaths is way down. And this may change some. We know that the state lab for verification of toxicology and so forth is obviously lagging at times, and so your last 12 to 18 months may tick up a couple. But when you compare 24 to 22 and 23, I think that there's a clear decline in the number of people who are actually dying from overdose fatality. So one could attribute that to a variety of things. I think the most reasonable assumption is the investment in naloxone and harm reduction, that we're reducing overdoses. I think our sheriff's deputies, our law enforcement office, or excuse me, our paramedics, fire departments, all the investment into harm reduction in a variety of ways, not just naloxone, has largely saved lives. So I think that's a positive takeaway and hopefully a lot of information that helps tee up what our goal is today with our Board of Commissioners. We have this is fairly new. Burke County's only been working on it for a couple of years under this opioid settlement concept. We certainly have a lot of new folks in leadership, including myself, and we want to make sure that we have good information, good systems, good communication processes. And as I mentioned earlier, I think that we are approaching the intersection of really a lot of valuable information. So for example, back, I guess, 18 months ago or so, the health department partnered with a group called the Fletcher Group to work on an ecological analysis, which is, I'll call it, for lack of a simpler term, a needs and gaps report for provider infrastructure that's in Burke County. So for folks who are ready for recovery, what are their pathways to success? What's here now? You can't necessarily do diagnostics and work on improvement until you know what you have today. We also are, as I've mentioned a couple times now, we're partnering with the Community Education Group to draft our strategic plan, to tell us a lot of the things that are in our environment, the types of conditions that we should be aware of. Later today, lower right-hand corner, we'll talk more about this, but we have a unique opportunity for a brick and mortar capital grant that's currently being held by our LME MCO Partners Behavioral Health, and want to make sure that we're considering all the different ways that we can utilize that to again support the systems that we're trying to build. And then we just walked through some of this 911 data, and the point is, once you put all of this together with the experience that we've had over the last 3 years, I think that it tees us up to evaluate where we've been, where we're at today, most importantly, where do we want to go over the next 5 years. Questions on that from the board, Mr. Chairman?
Any questions on these items from the manager? All right, carry on.
That's my part, and you can turn it over to Nick. And you do it.
All right. Glad to welcome NCACC, our folks, County Commission Association out of Raleigh. With us today, we have Elizabeth Bruton, and this is Nettie. I'm going to take a shot at it, Nettie, but Slotniva, way wrong, so why don't you say it for us?
No worries. Good morning, everybody. I'm Nidhi Sachdeva.
Okay, thank you
Yeah.
very much. You got that just right.
Thank you.
Peyton Williams also, I think, yes, there's Peyton, with us today from our association. Thank you guys for being here.
Such a pleasure to be with you all. Thank you for having us. I'm here with my colleagues Elizabeth Brewington and Peyton from the association. We are here.
Eddie, if you will, step a little bit behind the mic or turn the podium towards you maybe. We can hear you better.
How's that?
Much better.
Much better? Cool. Thanks for teaching me how to navigate. So yeah, I will start. Hello, everybody. I'm Nidhi Sachdeva. I just want to explain a little bit about my last name. It means seeker of truth, which I think is pretty appropriate, or that God is truth, which again, appropriate. And so here to share a little bit about what I know about the North Carolina opioid settlements and some of the context across the state. So I appreciate the primer that was offered before me, but I'm going to sort of take us up a little bit to sort of the bird's eye view of the whole state of North Carolina, and then try to dig in a little bit deeper into some of the strategies that are available to us through the national opioid settlements. And so I'm, like I said, here to represent a larger team, but I'm with the North Carolina Association of County Commissioners, and our vision is to empower all 100 counties to work together for the betterment of one state. We are here to support and promote the well-being, which is where all of our health programs work fits in for all of North Carolina through the advocacy, education, research, and member services. So the Opioid Settlement Technical Assistance Team.
Excuse me, I hate to interrupt, but we're still having a hard time hearing.
Okay, was this a little bit better? I'll just snuggle up to the microphone. Does that feel okay? Cool. All right, just imagine the podium is not here and that I'm with you in this conversation. Is this a little bit better? Cool. I'll take a look, make sure that I keep an eye on you. Tell me if you need me to slow down too. I get really excited about this work, so I tend to talk a little fast. But again, with the Association of County Commissioners, very much here to support all of our local governments who are receiving opioid settlement funds and doing this work and try to make our North Carolina counties healthier. That's ultimately our goal at the Opioid Settlement Technical Assistance Team. And my directive is to support local governments in making decisions and understanding what the national settlements sort of offer us as an opportunity to recalibrate, to sort of recommit, to get fired up and do our best to implement programs, evidence-based strategies to try to save lives. That's basically what we're here for. So the Opioid Settlement Technical Assistance Team, or OSTAT, as we affectionately call it, is really here just to help local governments understand kind of what's up, which way is up, what's allowable within the MOA, how they need to meet all the requirements for reporting, how we can coach them through all the process, the sort of the mechanics of the settlements, as well as capture what's working and then share that with others across the state. And so this is my hope, having done this work in North Carolina for over 20 years, really just that all people in North Carolina are healthy, have connections to supports and services within a culture of care. And I think it's going to be really important for us to work sort of across the social ecological model and understand that we are all individuals that are within our communities and within sort of a larger context, and that interventions that work across multiple levels will really help us get to our goal of having people be healthy and happy. And so I am part of one organization, the Association of County Commissioners, that's part of CORE NC, which is the Community Opioid Resources Engine. We are essentially the sort of infrastructure around the settlement in North Carolina. And so we are a very close partnership with the North Carolina Department of Justice, the Department of Health and Human Services, obviously the association, the League of Municipalities, and UNC's Injury Prevention Research Center. And so we all have sort of a different role. DOJ is sort of the keeper of the MOA. We are very much the technical assistance providers. We work really closely with DHHS to sort of help understand the evidence and what is happening across the state, as well as our data. So a lot of the data that was shared this morning comes from our partners over at DHHS, and then UNC's Injury Prevention Research Center is really our sort of data hub. So where all of your reports end up going, and they process and clean and then post all the results up on the website. So couldn't do this work without each of our partners. Also just some historical context. The national opioid settlements are, sorry, went too fast, are a collection of many, many, many settlements. And so our Department of Justice, along with sort of a coalition of attorneys generals all across the country, have been working on this for years. But essentially, when I say national settlements, it's a collection of many defendants. So it's the drug distributors, the manufacturers, the pharmacies, all sorts of different folks are at different points on the chain of how we made opioids and got opioids into communities, and all the sort of mess in between. So just some context there. And like you mentioned, the Purdue settlement did just get in principle approved in the courts, and so there are some steps that need to happen that we will sort of wait and see, just finalizing the courts. But I imagine that first payments from the Purdue settlement won't come until maybe next year or late next year. We'll see. But essentially, we sort of talk about this collection of settlements in that in waves, and so we have just entered into to the third wave. But basically, it's pots of money from the distributors, the pharmacies, and then the Kroger settlement. But it totals to about $1.5 billion coming to North Carolina over the course of 18 years. We're in year 2 or 3, depending on which local government you are, but this is, again, a significant opportunity for us to really rally and recalibrate around what we want to do. Unfortunately, overdose deaths are the leading cause of death for people under the age of 50. This is when we're supposed to be living our prime life, starting our families, building businesses, doing whatever we need to do to care for our communities, and so I think we have some work to do. But the legal framework, as mentioned before, is under the North Carolina Memorandum of Agreement. And so this is basically the agreement that all local governments have signed with the state of North Carolina to say these are the terms and conditions of the settlement. Basically, it splits up the pot of money, that $1.5 billion, into an 85-15 split. With the work of the association, we were able to negotiate the largest portion of funding to local governments across the country. So there's like 50-50 splits, 70-30s, but in North Carolina, we were very clear on saying people who are closest to the problem or like closest to the solution, we've got to get money to the communities where they know best. We have a big geographically diverse state, and so we want to make sure that we are able to respond to the needs that are locally experienced, right? So the local conditions. You all have many strengths. You all have much to build on. The settlements are one piece of the funding or financial puzzle. There's also still federal, state, private philanthropy monies coming into communities. And so even though it is a meaningful amount of money, I won't, diminish that. It's not enough to really get us to where we need to go to improve these systems of care over time. And so I think we at the association were very committed to saying, nope, our counties know, our communities know, we must get the money as close to the people as we can, and so that's why we negotiated this 85-15 split. So 85% goes to all 100 counties and 17 of our largest municipalities in North Carolina, although some cities have said, we think it makes sense for our counties to handle it. They do health and human services, we don't necessarily do those services, and so they're working in partnership to decide how they want to spend those funds in those cities. But 15% goes to the legislature, so they get to decide sort of what to do with those funds as well. So the payments, as I said, is coming over time. So it's sort of front-loaded. Most of the funding comes at the beginning. People ask me why this is, but because, remember, we're working with many defendants, they've sort of individually negotiated what they think is feasible for them. Some companies are in a better position to pay out their settlements within 3 years, the Walmarts of the world, for example, but then some of the smaller companies need a little bit more time. And so that's where the 15, 18 years. I just want to also remind folks that this is unlike a grant. We're used to 1, 3, 5-year grants we get really excited about. So this is a really unique opportunity that we can really plan towards the future, right? Also, these settlement funds do not expire like a grant does, and local governments are not required to spend the money in the years that they receive it, which means that they can think through sustainability starting at the beginning, right? And so I just want to let people know that it's a little bit different than like a typical grant. There are 5 broad requirements for local governments in North Carolina under the North Carolina Memorandum of Agreement. The first one is to establish a special revenue fund. So these are learning from the lessons of the past, right? So the tobacco settlements are the largest settlements in our history. These are the second largest, and we're learning that just to keep clear boundaries around what the dollars are meant to be for, that we want to keep it in a special revenue fund. It's just easier to track, easier to report, and just keeps things nice and clean that way. And every local government in North Carolina is doing this. The second requirement is to authorize spending ahead of time. So local governments are required to sort of publicly declare upfront what they intend to spend the dollars on. And this essentially allows us to know the plan, right? So we don't, in public health and, community health and public policy, you don't always see the results of the work you do on day one. So this is essentially like giving us a goalpost, like we're working towards this strategy or working towards this plan. And so local governments are required to authorize ahead of time. We have, as of the most recent update to the dashboard, which is the North Carolina Opioid Settlement.org dashboard, 90 governments have approved local spending plans out of the 114, 112, and 88 of those local governments are doing option A, which I'll explain in a little bit. But also just a note that like what we're finding through the reporting process is that some local governments, understandably so, are choosing to spend down grants that they already had before they tap into the settlement dollars. Say if there's a program that they've been running that they want to keep going and sustain it with settlement funds, they might spend down the grant money and then pick it up later with the settlement dollars. These are the 12 strategies. I'll go through each of these in more detail, but this is option A, 12 strategies included. I just wanted to give you a sense of what the most popular ones are so far. Essentially, recovery support services, 59 of those 90 local governments have selected recovery support services as a very broad category. Naloxone distribution is second, collaborative strategic planning, post-overdose response teams, and then evidence-based addiction treatment. Those are just the top 5 so far. So, just a note, as commissioners, you will see these come up time and time again. So, because of that requirement to sort of pre-authorize funding with the settlement dollars, you will, as commissioners, have the responsibility of signing a resolution to sort of allocate those funds to a specific strategy or project. And so we have, at the association, created a template just to help make sure that all local governments are meeting the very specific requirements of the MOA. So it has to be, these monies are from the opioid settlements to do this thing for this amount of time with this amount of money. So we have many resources at the association through OSTAT to help you sort of with those mechanics. But you'll see these come across your desk. Oh, baby. Hi. So the local view dashboards, I know you all have seen, explore this website, but we really are very proud of what we've been created in North Carolina. We're sort of the envy of many other states. We get lots of calls to say, well, how did you do this? But with the spirit of transparency and accountability, we were really quick to put up sort of a go-to one-stop shop for all things opioid settlements. And so this website, ncopioidsettlement.org, I will repeat that a bunch of times, so everybody needs to know that before they leave this room, essentially has lots of goodies. It's got the payment schedule, so especially as that changes, so once the Purdue settlement is finalized, the payment schedule will be updated. It's got all the local spending plans that local governments have passed. It's got past spending reports, so not only what do we intend to spend money on, but what did we actually spend money on. If you do decide to go the Exhibit B route, there's all the collaborative strategic planning reports. There's also annual settlement updates and sort of a local contact. And so every North Carolina local government that's getting settlement dollars has their own page. We thought that this would be a really great way just to sort of go there, check in, and have everything sort of compiled in one spot. So take a look. The third requirement, which is what I'm going to spend most of the presentation in on, is to understand and follow option A or option B. The NCMOA, I'm sorry about the alphabet soup here, has many parts to it. So the first part is, again, those mechanics, what's required, what you can and can't do with the money, how you need to store it, move it, that kind of thing. And then there's a bunch of exhibits. And so Exhibit A is what we casually call option A, and Exhibit B is option B. And so the main difference, like Brian said, was that option A is sort of a short list. It's the high impact abatement list that's essentially like vetted, and we know that we've got really good examples of this working all over the state. And it's just on day one you can go ahead and do these strategies. They've sort of been filtered through and prioritized, and honestly incentivized, because it's just we know this stuff works. We know we're losing 8-9 people every single day in North Carolina. Let's get this stuff going and go for it. And then what I like to think of as option A is sort of the strategies that are closest to the people that are at highest risk for death. And so like, how do we get services and supports to those people that are at highest risk, most urgent need, is what option A is. Option B is a much longer list. It comes from the National Opioid Settlements. And it's a little bit more about the sort of systems of care, sort of the ripple effects that move out from the person that's highest risk. So that's where some provider networks and primary prevention and things that are a little bit more removed from that person that's immediately at risk for death is an option B. And so it takes more time to sort of activate those and see the results of option B. All good things, but we just have to pick the right path for us. And so just sort of, this is where the nuances can get a little complicated, so like I'm happy to answer questions at any point. But basically, local governments can choose to do option A and option B at the same time if they want to. That's okay. They can, if you wish to select an option B strategy, there is a, sorry, I'm like, yeah, so like everything on A is also on B. But not everything on B is also on A, which makes sense, right? It's a much longer list, it doesn't all fit. And so just want to say that if there is a strategy that is on B that you like that's similar to A, then we can coach you to try to find out the right categorization. And so just want to say everything on A is on B, but not everything on B is on A. If you wish to consider like lots of different activities, that's, that makes sense, but just know that for every strategy that you authorize, you also have to report on it. And so there's sort of a balance that we need to find. We want to have a diversity of strategies, right, because we want a comprehensive approach to the problem, but we also just have other requirements as well. So just wanted to put resources, when it becomes time, it'll become relevant, but if a local government decides to go to option B, that we've provided worksheets and just, again, ways to help local governments make sure they meet every single one of those steps and requirements. So, I'm going to take a pause. I had a hand, questions, I'm going to grab myself some water.
Question. You mentioned the defendants quite a bit. I'm kind of interested in the plaintiffs and the lawsuits and what has never really heard a lot about that information yet. If named organizations are entitled to compensation or if other things are being discussed.
Sure. So this is DOJ's obviously expertise. There's a lot of this that I don't hear about, but plaintiffs are basically the states and the localities and local governments, essentially. The Purdue settlement is going to be a little bit different in that there is a separate pot of money for individuals. I have no idea how they're going to manage this. To me, that sounds very complicated. But there is different plaintiffs for that settlement, which is, again, is yet to be completely finalized. But generally, the plaintiffs are states, localities, local governments. Does that fit with what you've heard too?
Sort of. In our particular case years ago, the settlement was, our lawsuit was brought forth by several organizations within our community. And I just would like to know a little bit more about that. I'm the executive director of one of those that was named as a plaintiff.
Gotcha.
So just kind of interested.
Yeah, on the ncopioidsettlement.org website, we do have a section that's about the settlements, and so DOJ has provided us all the details with each of the different cases that they've sort of taken to court, and you can take a look at there, the historical record of each one of those cases, plaintiffs, defendants, and what the outcome of them are, especially if they've been finalized. Hopefully that helps. All right, so now I'm going to do a little dance through all of these option A strategies, just to give people a sense of what we're talking about here. In my dream, again, I had a hope at the beginning, now my dream is that eventually we will have all 12 of these strategies in every community in North Carolina over time. But I do appreciate and understand that everyone is starting in a different place and that they're moving at a different pace, and that is okay. But we certainly are here to support local governments and wherever they decide to start. I have no one is better than the other. I think they're all needed. And so I'm going to, like I said, dance through all of them just to give people a primer to sort of help understand kind of where the parameters are of what we're talking about here. So, you ready? Okay. Collaborative strategic, we have first filter though, sorry. Just a quick level set, right? So what are we talking about here? When we're talking about the national opioid settlements, right? Leading cause of death in North Carolina, leading cause of death for people under the age of 50 is opioid overdose specifically. So because there's that urgency, the opioid settlements are staying within those bounds, right? So the defendants are saying, I'm putting words in their mouth, honestly, but the defendants are basically saying, our bad, we messed up, and that we want to make it right. But we also are not here to solve all the problems of the world. We're going to focus on this one. And so The opioid settlements are really focused on opioid use disorder, this idea that people are at highest risk, it's the most lethal at this time, and so we don't want to dilute our efforts, but we understand that people are complicated creatures, and we all deal with many challenges, and that we can't separate ourselves from the experiences that we might have. And so at the very top of the page on option A, it says that in line with the National Settlement Agreement, right, so let's make sure that we don't put any of our local governments at risk from losing money by going too far outside of the scope of what the national opioid settlements are, we can support programs and services that serve persons with opioid use disorder or any co-occurring substance use disorder or mental health condition. So the opioid use disorder, or the history of opioid use, has to come first. That's essentially what this means. But we understand that if someone shows up at our door or our EMS answers a call, we don't always know who we're going to come across. So we're not saying we don't want to serve them, but we also want to say we have to prioritize these limited resources for people with experiences with opioids to stay within the bounds of the National Settlement Agreement. So people are like, well, what about alcohol? What about other drugs? I'm like, I can appreciate that. There's lots of layers. Most of the time, substance use disorders, mental health conditions come with it. We don't always know which one comes first. But we also just need to understand the bounds of the settlement, what this opportunity is really being focused in on, and then prioritize folks that are at highest risk for that death, right, with the most lethal means. All right, so collaborative strategic planning is the first strategy. It's essentially says that local governments can use it to support planning, assessment, and coordination, and so staff support. So this is where a lot of local governments are building infrastructure around the settlement, so like where they hire their coordinators, where they do a lot of their sort of analysis of data, where they support the work that needs to fulfill the reporting requirements, just again, the mechanics, the infrastructure that is local in local governments. Essentially, it's a structured process. I like to think of it as a funnel where you sort of look at the universe of what it could be, and then based on a step-by-step process, we say this is what our data is, this is what our gaps and needs are, this is what our priorities are, and then you narrow the list down to what the top strategies in your community are. And so there's a big emphasis and encouragement to get input. I think you all have been doing some of that efforts already, which is great. And so really learning and understanding for people who are living it what's happening, right? So our data, can be a little bit delayed, and so the people who are closest to the problem are the likely ones to tell you first, this is where the systems are failing us, and then how can we do our best to fix it? So there's a big emphasis on listening to people who use drugs, people with lived experience, who can tell you. Exhibit C, again, this alphabet soup, has a very detailed step-by-step process for what that means in option B. This is just a snapshot for reference for later, but this is steps A through N. If you do decide to go option B, you have to go through every one of these steps and document every one of these steps. DOJ is very much looking at, did you fulfill the intent of the process, again, looking at the universe, and then justifying each decision point and narrowing it down to the prioritized strategy. So A through N for reference later. These are the required stakeholders included in the collaborative strategic planning process, and so this is, again, encouraging a diversity of voices. We understand that some people might fall into more than one category, but essentially we want to engage a wide variety of perspectives. So here's the list. All of them are required. If one is missing, then you haven't met the needs or fulfilled the requirements of the collaborative strategic planning process. All right. Strategy number 2, which is Exhibit A, strategy number 2, evidence-based addiction treatment. The goal of this strategy is to increase access to medications for opioid use disorder. I am amazed to say that we have a cure for the leading cause of death for people under the age of 50, and that is medications for opioid use disorder. Gold standard of care. The idea is, how do we get this treatment to more people, more places, in an affordable way when they need it, essentially. And so the requirements in the MOA say that to be evidence-based addiction treatment, you have to follow the American Academy, the American Society of Addiction Medicine, I always get the letters mixed up, but the ASAM guidelines, which says that medications for opioid use disorder must be offered. That has to be an available option to be considered evidence-based addiction treatment. So the idea is to get them available in many places. In North Carolina, we have been doing a pretty good job of this, but we have worked on increasing access to medications for opioid use disorder, or MOUD, through office-based clinics. That's like primary health care, for example, opioid treatment programs, or methadone clinics as they've been called, through hospitals, through emergency departments, as well as inpatient care services, EMS bridge programs, this idea of sort of inducing someone in the field, getting someone started on MOUD, especially after an overdose, and then get connected to a home, a medical home. Federally qualified healthcare centers, local health departments have also been offering MOUD if they have primary care, through our jails and prisons, and then through syringe service programs as well, and other community-based organizations. And so the evidence behind evidence-based addiction treatment is that it improves patient survival. Again, it's the cure for the leading cause of death for people under the age of 50. It decreases overdose, withdrawal symptoms, transmission of communicable diseases like HIV or hepatitis C. It decreases illicit opioid use and other criminal activity among people with substance use disorders. It also increases patients' quality of life, the ability to gain and maintain employment, for example, and improves birth outcomes among pregnant people who have substance use disorders. So this idea that it sort of clears the mind, right? So if your body is in survival mode and you're like, I will die if I don't get this thing, then it sort of eases that noise in the head and allows them to make the next best decision, sort of clear space to be able to live their life and get connected, reconnected. So MOUD is a broader category, but it includes methadone, buprenorphine, and naltrexone as sort of the medicines underneath that MOUD. I'm not a clinician, so if there are clinicians in the room, please forgive my very layperson language, but this is what I got. So, what I love about the Option A strategies is that it does a really good job of like not only working on sort of the personal experience of the medical condition that is opioid use disorder, but it also sort of wraps people up in those community needs, right? So we're all humans, we have basic needs. I like to think that drug use is sort of a symptom of much deeper societal ills or personal struggles. And so it also acknowledges that we have to sort of build the foundation under people so that they can stand up again, right? So strategies 3, 4, and 5, I'm sort of grouped together in my mind as sort of general recovery support, sort of basic needs, access to housing, as well as access to employment or an income that can sort of help people find stability, right? Because that's what really helps people stay safe for the long haul. And so strategy 3 is basically, this is the hierarchy, you've probably seen this, Maslow's hierarchy of basic needs. Recovery support services sort of fits in 3. The physiological needs is the housing, and then safety needs is employment. So recovery support services, A3, is really about funding evidence-based recovery support services, including peer support and care navigators. So they can be based in many different kinds of organizations. Peer support as a staff person is an eligible expense, and pretty much every one of those strategies is an option A. But essentially, it's to help, walk with someone through the experience of finding recovery, safety, health, and happiness. With someone who sort of lived it and sort of like, I get it, it's hard, I'm here with you, let's figure it out together. And so peer support, it really helps make all strategies in option A better. And so this is a strategy that a lot of local governments are choosing to do. But it's good. So recovery housing support is really specific to finding housing for people who use drugs or are on medications for opioid use disorder. Some example expenses could be for emergency rent, deposits, or utilities assistance to sort of help people stay in the homes that they already have. I think all of us are experiencing sort of a housing crisis and the pinch of living expenses. And so this is a universal burden on all of us. But for people who use drugs, losing housing can be really, really destabilizing. And so how can we do our best to keep people in a place where they can, again, clear space to make the next best move for them? So it's really prioritizing housing first. Not necessarily, it's kind of funny, I think about this sometimes, but like drug use is a weird thing. It's like we require someone to stop the symptoms of the disease before we actually offer them help, which is sort of backwards from what we do with everything else. And so it's this idea of like, how can we do our best to, again, keep people safe and give them a spot to then be able to access all the rest of the services. So employment support is this idea of how do we get people back to work? How do we find purpose and meaning in our days? And so funding programs that offer employment support services to people who use drugs or in treatment or recovery. And this can mean everything from job training to working with employers to incentivize hiring people who are in recovery or are using medications, Also working on changing workplace policies to make it sort of more accessible to show up to work. Like say someone is in, successfully stable in a treatment program, but they have to have a visit every morning. Like maybe they can start a little bit later in the day. Like what are some flexibilities we can have to help people stay in work? And then they, contribute to the tax base and all that kind of stuff. So early intervention is one of the more challenging strategies on this list. But this essentially is identifying risk factors and increasing protective factors. So it's focused on young people and adolescents. But we have to acknowledge that trauma is really the gateway drug here, that childhood experiences, adverse childhood experiences are often what sort of lead folks to finding some kind of relief in adulthood, right? So if we can do our best to prevent the trauma in the young person's experience and alert the adults around that child to sort of recognize signs and symptoms that this kid is struggling, but they may not have the words to tell me where it hurts, how can I intervene and say, what happened, how can I support you, and then what do you need, right? So it's really about supporting and most kid problems or kid challenges are adult problems, right, to fix. We all, I think, understand that. And so how can we do our best to prepare those adults to intervene and prevent childhood trauma? And so I want to differentiate early intervention from primary prevention. Early intervention in Exhibit A is really about serving those kids and adolescents who are already showing signs of struggle. Remember, option A is about the people that are at highest risk for bad outcomes, right? And so it's really focused on a population of kids who have sort of raised a flag in our minds that this kid's going to need extra help. So, for example, do they have signs of anxiety or depression in middle school? Do they have a parent who's going through a hard time that's affecting the child? How can we support the family unit? It includes things like, just trauma-informed systems within a school, or having counselors sort of say, well, golly, this kid is acting out in school, but I don't know what's going on. How can I do my best to support this kid who's showing signs of struggle, right? They don't have the vocabulary, but they're showing signs. So that's what option A is. Primary prevention is usually about delaying the onset of drug use or preventing the misuse of drugs and opioids. This is much more universal. This tends to be more about like a whole school or a whole school district or a whole community or neighborhood, right? It's not focused in on those kids that have sort of raised the flag in our minds that this kid needs help. And so that is an option B strategy. So remember, it's a little further removed from that kid that's really struggling. So I just want to differentiate. So this is a lot of what we get in our opioid settlement technical system questions are just like, we want to do this and we want to do that. And I'm like, cool, let's figure out a way to do that, but we have to make sure we categorize it in the right spot. Okay, naloxone distribution. For folks in the room who might not know, naloxone is a medication that does nothing but reverses an opioid overdose. Usually an opioid overdose is experienced when someone's breathing and their bodies are depressed so much that they lose oxygen to their brains and they could die. And so what naloxone does is essentially it's a stickier medicine. It sticks to the brain receptors in your head and it knocks off the opioids and says, no, you have to breathe again. And then your body just like wakes up. So it's pretty amazing, but it does nothing else. If you don't have opioids in your body, it doesn't do anything. But if you do, then it helps restore breathing and sort of kicks in the two safety features in your brain that tell you that you don't have enough oxygen and there's too much CO2 in your body. And so this is like first line of defense. Like if you're working with people who use drugs or use opioids and you're doing any of this work, I'm so like impressed and proud and appreciate that you all started here because this is like first aid, right? We got to keep people alive. No one can make a choice tomorrow if they're dead, right? So like how do we do our best to get naloxone to as many places as we can? And that can be through certain service programs in our jails, through health departments, hospitals, community gathering places, anywhere. But it's over the counter now. There are some formulations that are cheaper than others. The intramuscular, which is where you inject into a big muscle, is much cheaper than the nasal. So just think about how far you want your dollars to go, but it's certainly a good place to be. Post-overdose response teams is sort of in that crisis response category, but evidence shows that people who overdose are more likely to overdose again. And so I think we all sort of feel it with our EMS that you are at front line, you show up, you see it. And so how can we do our best to support linkages to care in those vital hours after an overdose, where you go to someone and say, golly, that was a really scary experience. I'm so relieved that you're still here. How can how can we do our best to support and connect you to care and services? So post-overdose response teams are very much about linkages to care. The magic formula is what I like to say is sort of an EMS paramedic combined with a peer support. That's sort of like the best way to do it. But essentially, having peers integrated into PORT means that they can follow along with someone for a while and say, again, scary experience, so glad you're here, what do you need now, what do you need in a week, what do you need in a month, and getting people connected to care. This is where a lot of innovation's happening in North Carolina. Our EMS have said, we keep coming back, but we want another tool. And so some of that access to medications for opioid use disorder, for example, through those EMS bridge programs are popping up under PORT, which I think makes a lot of sense for us to get people bridged essentially between an overdose experience, to medications, and then connected with a longer-term provider. Syringe service programs is also on the list of evidence-based high-impact abatement strategies in Exhibit A. Syringe service programs, or SSPs, were legalized in North Carolina in 2016. They cover about, I think the last I heard, over 80% of North Carolina counties. They essentially are a touch point, an opportunity to have a conversation. They are reaching the people that we often in our systems of care have the most trouble reaching. They are essentially offering many, many services. And so one of my mentors has said that certain service programs are like when you go to a conference and someone chases after you with a pen, and they're like, hey, here's a pen, and you'd take the pen as like a little giveaway. And they're like, well, then you start having a conversation. So the syringe is really about starting the conversation. That's not really what it's about. It's about engaging and connecting and saying, I see you, let's talk, let's get you connected, what do you need? And so that syringe is really about, you come for syringes, but you stay for hope, is what my mentor likes to say. And so in North Carolina, by law, syringe service programs are required to provide these core services, which are educational materials, access to sterile supplies and syringes, secure disposal, although in North Carolina you can also wrap it up in a hard plastic and throw it away in the trash, just like diabetics often do. Naloxone kits and referrals, and then referrals to mental health and substance use treatment as needed and encouraged by the actual patient. But what we're finding through their annual reporting process is that certain service programs are actually offering tons of additional services because they are often that safety net, right? It's that touch point. And so they offer everything from referrals to housing, and again, like I said, medications for opioid use disorder. They are often the peer supports on post-overdose response teams. They help with HIV and hepatitis C treatment and testing. They do job training. They help people fill out applications. I mean, they do a ton of work because they have that relationship. They have the trusting relationship. All right, so criminal legal system. I'm going to sort of take a step back. 10, 11, and 12 in option A. The reason why the North Carolina Memorandum of Agreement includes these 10 strategies, which might feel similar to other ones, is because in North Carolina, people that are being released from incarceration are 50 times more likely to die in those first 14 days. And that's when they're on your community supervision probation, they're coming out of your jails. And so that key window is really scary, right? And so 10, 11, and 12 is all about working across the continuum of services for people who are at, most risk for overdose death. If you're involved in the legal system and you use drugs and you're coming out of jail, we don't make it really easy for y'all to get settled into community again, right? So how do we do our best to release the pressure from our jails, keep people out of a system where they don't really need to be? Because our jails, unfortunately, are our most common mental health provider in our country. They weren't set up for that, but they certainly are having to do that. And so diversion, criminal legal system diversion programs, strategy number 10, is all about getting folks connected to health care as needed rather than getting them into our jails. And so these are providing an alternative for incarceration and getting people connected to services, especially for low-level offenses, stuff that's really a symptom of the health condition, the drug use. MOUD in jails, which is, again, I'm using these acronyms, I'm sorry, but Medications for Opioid Use Disorder in Jails and the American Disabilities Act. So essentially, strategy number 11, similar to 2, but because medications within a jail setting is so unique, right? It's such a specific setting. We understand that you need different kinds of supports. And so that's why it's separated out for that population that's such at high risk. So the idea for 11 is to encourage access to medications for opioid use disorder within the jail setting. And there's a requirement in the MOA that you must have at least one FDA-approved opioid agonist. So that means buprenorphine or methadone. And there was some guidance that came out of the U.S. Department of Justice in 2022 that explains that people who use drugs, people with opioid use disorder, are protected under the American Disabilities Act. That is a group that is considered someone with a disability. And so if you do not continue someone on their medications while they're in your jail, then you could be violating the American Disabilities Act. So not a good place to be for a lot of different reasons. Again, risk of overdose death, risk of financial liability, it's not a good spot. So essentially what this means is that if someone, say I am someone with opioid use disorder and I'm on medicines, if I come into your jail, you have to maintain me on the same medicine that I've been on and not disrupt my care. Just like if I were someone on blood pressure medicine, same thing. You have to maintain me on my medicine while I'm in your care. All right. Number 12 is reentry programs. Again, we're looking across the spectrum of involvement in the legal system. We're trying to deflect people away from it where they probably are not best suited. We're trying to help them while they're with us in the jails. And we're also trying to help them reenter society through reentry programs. And so it's essentially helping people connect to social health services once they're being released so that they don't come back, right? Because that's real, this recidivism, revolving door is real expensive. And so how do we do our best to support them with community-based resources to prevent that cycle or to break that cycle? And so upon release, it's about helping people get hooked up with housing, with a medical home, with continued medications, with a job, with a place to stay, whatnot. And this is another place where community health workers and peers are really, really vital. Someone who's experienced the legal system and can sort of say, this is what it's like, let me help you navigate. All right. Whew. Take a breath. Everybody with me still? Okay. So, the fourth requirement for the NCMOA is to follow all the reporting requirements. Reasons why this is important is one, top of the list, it's an MOA requirement. All local governments are required to do it. It guarantees transparency, and it's an opportunity for us to document our efforts and celebrate our successes. I'm so grateful that the curve has been coming down a little bit. To be honest, I've been doing this work a long time. I'm kind of holding my breath because I don't know what's going to happen after Helene. Like, when there's a natural disaster, we've seen overdose numbers go up, and so it means that, like, yes, what we're doing, access to medications for opioid use disorder and naloxone, is helping bring that curve down. A lot of thanks to the community-based organizations that are doing that work. But like, I'm just like, it's gonna happen, and I'm just praying that the people that I love stay safe. And so we've got to keep doing this, even though the data is encouraging. We got to keep going. We got to keep going because there's going to be blips and there's going to be pressures from outside. So, side note, apologies, but this work really matters. So, the reporting requirements, not nearly as exciting, but very important. So, there are 4 reports the local governments are required to do. The first one is the local spending authorization report. So remember the requirement that you have to pre-authorize funding before you spend it. So you can't like reimburse yourself or do, backdate start dates for projects. But once you've passed a resolution, then the county will submit a local spending authorization report to CORE-NC, that big sort of data repository that says this is what we intend to spend money on. So within 90 days of passing a resolution, you will submit a report. You can submit you can approve as many resolutions in a year, you can submit as many resolution reports as you want, but it has to happen within 90 days. And then in September 27th, which is the 90 days after the end of the fiscal year, local governments are required to submit 2 reports. One is an annual financial report, so basically what did we spend the money on the previous year, and we have to submit an annual impact report, which is basically, what good did it do, is essentially what that answers. And then if you do decide to go the Exhibit B route, that longer list with the required collaborative strategic planning process of doing every single A through N step, you also have to submit a R&R is sort of what we're calling it for short, but it's a option B report and recommendation. So after the county presents the recommendations to the board, then they will submit the 90-day, or within 90 days, this R&R report. Transparency and accountability also for any county staff or community-based organizations in their room. Not only do we sort of serve and like support the MOA requirements, but we can help answer questions about all reporting. So for every dollar that is spent under the settlements, no matter who spends it, whether it's the county, a county department, a community-based organization, all the MOA requirements apply. And so that means that any subcontractor, you've also got to meet those reporting requirements. So help us help you, help the county get their reports in and have it all compiled up in the best way we can to be able to capture the story, the full story of what y'all are doing in the community. The fifth requirement for counties is to hold annual public meetings. It has to happen at least once a year. The MOA does not differentiate between calendar year and fiscal year, but because you have to report on it in your annual report, which are on the fiscal calendars, it just makes sense to kind of get in the rhythm of doing it once every fiscal year at least. You can have more of them, but at least once. The county invites all, if any, municipalities to join in. Again, this is trying to encourage that collaboration. Obviously, the meeting has to follow all public meeting laws and rules, and the whole point is to collaborate, to coordinate, and then also like engage in planning, shared planning, and then sharing progress, essentially. I also just wanted to point out that OSTAT has, again, put together a ton of resources to help you with the mechanics of the settlement, but one of our biggest resources is the Local Government's Guide to RFAs, or Request for Applications. This process is not required by local governments, but if you do decide to do it, we've given you essentially a template. Like, here's all the boilerplate language around the settlements. Again, for every dollar that is spent under the MOA, it has to follow these rules. Here are the, here's some suggested language, just to sort of take some of the burden off of the local governments in crafting this RFA, and then you can decide which strategies you want to prioritize, which ones you want to put out for bid or not. Like, for example, if a county is doing a county-based program and like EMS-based program, for example, they'll just fund the EMS program, but they might want to also reach out to community providers to fill in a gap that they can't necessarily do within the county government. So it can be a combination. Anyway, these are some resources to come back to. Again, the ncopioidsettlement.org website, which is our core NC website. The Opioid Settlement Technical Assistance Team has resources that are specific to local governments, again, about those mechanics. The Department of Justice, if you have questions, you can email them. And then, of course, DHHS, this is the state dashboard with a lot of the data that Brian shared, and then lots of other good stuff. If you want to reach any of us, it's opioid settlement at, and then whatever our respective organizations are. I also want to offer an invitation. The North Carolina Association of County Commissioners is hosting the North Carolina Summit on Reducing Overdose. We've been doing these for about 10 years in the state, but this is the second time that the association is hosting. It'll be March 18 to 20 in Wake County at the Raleigh Convention Center. It's 2.5 days. It is a crash course, full orientation. It's going to be a great opportunity for us to just like learn what's happening in different places. We have 25 breakouts, 5 skill-based workshops, really great engaging keynote speakers, and it's going to be a really good time. So hope you'll come. It's, again, a really great time to talk to others about what they're doing, learn what's working. We've got a bunch of counties featured, as well as community-based programs, and I'm excited. Can't believe we're only a month away. Also, just want to give credit to the effort of the association to sort of help local governments rally behind this very timely opportunity. And so the association had a One More Thing campaign where we basically were encouraging local governments to collaborate and to learn from each other to be able to sort of build momentum around this opportunity, because you are in such a unique place to make decisions about the opioid settlements. We know it's a lot of responsibility. We know you all have to think about a lot of different topics, but given that the settlement came to us 2 years ago, it felt like a really timely opportunity for us to say, let's all get oriented and rallied and do some good work. I also want to give credit to the North Carolina Opioid Settlement Coordinators Network. So as part of our job as OSTAD, we do our conveners, and we are building a workforce across the state of people who know and are passionate about this topic. Opioid settlement coordinators in counties sit in lots of different places. They might be within a county manager's office. They might be with the health department or EMS, or where the leadership sits matters less. It's like whatever works for you. But they're passionate and committed, and this has been one of the highlights of my last year of pulling this group together, where we don't feel so lonely in the work, right? You might be that one person in the county doing the job, but you are connected with many, many more people who care a lot about you and who care a lot about what we're doing together. Also wanted to just do a quick little plug for trauma-informed counties. Remember I said that trauma is the gateway to drug use, and also being in a position where we are servant hearts in Health and Human Services through county government. Trauma-informed services sort of offer two things. It gives us a chance to have stronger internal supports for staff. So our Health and Human Services has the highest turnover within our workforce. I think that's probably true here, like it is in most places. And it also helps us improve our services for our communities. And so we are doing a series of trainings around what trauma-informed services look like. And then we offer for counties who apply or are sort of ready to do it, a trauma-informed counties in practice program where we do everything from document review to sort of understanding what is working, what is not, what staff supports might be needed, and then offer a list of tailored recommendations to you to say, well, how could we make our county services overall more trauma-informed so that we're not like making it harder for us than we need to, right? So like if someone has a fantastic experience with EMS, but then has a not so great experience with DSS, no offense to the DSS friends in the room, like we're kind of shooting ourselves in the foot. We're making it harder for ourselves, right? But we want, as a county, to say, you have a good experience with us. We are offering consistently high-quality services, and we support our workforce because we need you to stay committed and dedicated to this work for the long haul. It helps us save money. It helps us make sure that we've got the highest quality. It makes us a good employer, all sorts of good stuff. So we're going to be opening up cohort 2 in the spring. If you're interested, we'd love to see Burke County on the list of applicants. These are our contact information, so the Opioid Settlement Technical Assistance Team, our website if you want to check it out, and then again, if you have any questions at any point, we are very much here to serve, so opioidsettlement@ncacc.org. We'll get to our whole team, and I know I just dumped a lot out on you all. Apologies, saturated with information, but I'm happy to entertain questions from the board as well as from the crowd.
right. Thank you, Nettie. Gentlemen, any questions for Nettie at this point this morning? Yes, sir.
Yes, ma'am. Thank you so much for the work you're doing. It's probably most important to me and everybody here, but as far as me being a new commissioner, the question that I have, without tying up too much time with all this information, is in your travels and in your work with all the different counties around our state, does a county or two really pop up in your mind that has moved quickly with the funds that you can tell? I know reporting is delayed somewhat, but can you see some counties in our similar situation that rank pretty far down the list with opioid crisis that really pop out that these counties have really taken quick action? We can see some good results even though it's early on. Does something pop out in your head? And could maybe you share a
You're asking me an
strategy?
impossible question to pick favorites. I don't have a favorite county. I love all of them equally, but I can appreciate in my Rolodex, that is my 117 local governments in my head that are doing this work, that there are quite a few actually that are, so I think what's feeling most encouraging for me, I'm gonna do program specific. I'm really, like I said, delighted about the EMS bridge programs and access to medications for opioid use disorder out in the field. I think that is really a gap in services, is where we lose a lot of folks in those sort of spaces between. I think that's been really important. Again, with the decreases in overdose recently and it being attributed mostly to access to medications for opioid use disorder and naloxone access. There are a lot of local governments that are doing those. Remember, those are part of the top 5. MOUD can look like everything from access through local health department primary care. That's been really encouraging. Oftentimes, they're the only primary care clinic in the area. There's also been some really great, all the jail-based MOUD stuff has been really encouraging because people are at such high risk. And so if we want to actually decrease overdose numbers, focusing on the population that's the highest risk, most in danger, with the gold standard of care, I think that's just a really smart choice. And so we're seeing more and more jails come online with medications for opioid use disorder for both methadone and buprenorphine, but they're doing it in really creative ways. And so, for example, some are working with their local OTPs, their opioid treatment programs, to bring methadone to the jail. So you're not transferring people. That's really a challenge, logistically challenging. But how do you bring methadone on site? EMS are also oftentimes working with their jails to bring buprenorphine to the jail. That's been really encouraging. Syringe service programs, whether they're county-based or community-based, again, it's how do we get closest to the people that are highest risk? And it is a low-cost intervention. It is like a 10-cent syringe versus $100,000 to treat someone for hepatitis C. I mean, it just makes so much sense to me. And so that is something that we've been building in North Carolina for quite a number of years. And peer support everywhere, like in treatment programs, within recovery support services, in post-overdose response teams, at syringe service programs, in jails, in reentry programs. People with lived experience, walking alongside somebody makes every effort that you do that much more effective. It just boosts up the work. So those are probably my, not having the whole Rolodex in my head, are the strategies to me that seem to be the most promising and seem to be the most sparkly. Like people are really like, this is working, let's do more of this. You're not going to make me pick favorites, sir.
Are there a county or two that just stick out in your mind? You don't have to tell me the county, but is there a couple counties that you just know are really hitting the ground running hard?
I don't know if it's a fair question because the settlement is a new opportunity, meaning it's only been here for 2 or 3 years, but the problem has not been here for only 2 or 3 years. So some counties have had a head start, to be honest. We've known about this issue in North Carolina for 10, 20 years. So public health has been working on this for a while. Like we were actually the first state in the country to sound the alarm that prescription drug overdose was a problem. It was no longer, poisonings were no longer the kids under the kitchen sink with the Drano. It was medicines. And we called CDC and we're like, y'all need to help us figure this out. And North Carolina was the one that said, this is a problem. So it's been an issue that we've been paying attention to for a long time. There's been federal investments, state investments, again, private philanthropy, which has been really encouraging. And the settlements are just sort of an activator. It's like a new boost in an epidemic that's honestly been going on for too long. But the ncopioidsettlement.org website, which I know you've been on, has the local spending plans. So you can click through and find which local governments are doing those key strategies. And that might help you narrow in on sort of who you might want to call and talk to specifically about what you're doing for Port here, or what are you doing with jail-based MAD here. And we can do a little dance around the map together another time.
Okay, thank you, Nettie. Any other questions for Nettie? Important. All right, well, at the risk of information and rear end overdose, we're going to take just about a 5-minute break. 5-minute break. That'll be about 9:48, and we're going to start right back. We have 3 more presentations to see this morning. So thank you very much. 5 minutes. All right, this brings us to the benchmarking and strategy sessions. We're going to look at other North Carolina counties and strategic planning that's going on. We're glad to have folks from the community education group. Did I get that right?
Yes, sir.
Thank you very much, Katie Varnado and.
There you go. You ready? Tell
Yeah.
me when you're ready.
I'm
This
sorry,
This is your party. I'm just happy to be a guest.
I don't have your name in front of me, and I can't remember it.
It's okay.
Please,
Hey, Tony Young.
Tony. Thank you, Tony. I apologize.
Don't worry.
We are ready to get started, and we'll hear from you guys now. Thank you very much for being here.
First of all, I want to thank you for the invitation. Second of all, I want to thank you for letting me steal Dr. V. I don't know if you had any say in me stealing her, but stolen she was. And so I'm glad to be able to bring her back home for a little bit. My name is A. Tony Young. I'm the founder and executive director of Community Education Group. We're going into our 30th year of service. And again, we're super excited to be able to share some of the work and history of what we do and what we think that we do rather well with you. So our organizational mission is to stop HIV when we were founded in women, children, and families, primarily those that were African American. In Washington, D.C. is where we got our start. But today we do work, and again, I told you 30 years, we do work in the Appalachia region and through many of the Appalachian states that I'll talk about in a minute. We do a lot of work in the training of community health workers, organizational development, capacity building, strategic planning and evaluation and assessment. We recruit and retain, hire individuals. This is the big money slide right here. There's supposed to be a train that's supposed to be coming that is not here. So, you have to, you got the, can you press play? Can you roll that bean footage? So what I like to say is, this is how I describe our work, that is this way, that there's a train that's roaring through the Appalachia region. The engine of that train is the OxyContin crisis that many of us know. It's now a poly drug use crisis. The next car on that train is hepatitis C, hepatitis B, hepatitis A, barriers to workforce development, barriers to educational attainment and economic development. We've also got barriers to access to HIV care and treatment. That's really what we call the syndemic of the opioid crisis right now. The job for us at Community Education Group, and dare I say, the job for you as a commission, is to be the boulder that stops that train in its tracks. And the way we do that, and I think that sounds like what you want to do, is bring resources, opportunity, and attention. For us, it's throughout the Appalachia region. And the Appalachia region is 423 counties, 13 states, with West Virginia being the only one state fully in the Appalachia region. And I bring this up particularly right now because I think that one of the things that the opioid settlement or opioid remediation dollars do is that it gives us a very unique opportunity. It gives us an opportunity to bring efficiencies in places where we don't have them now. And when I say that, I mean this, is that opioid settlement dollars are not necessarily constrained by federal policies, programs, or ideas. What you get to do is have, again, as Nidhi pointed out to you, from option A and option B, there are many things that you can do, but you also have a lot of flexibility, I would say, in how you do that. Now, I bring this up right now because one thing happened yesterday that I think we have to begin to figure out how we include this. And what happened yesterday is that the White House came out with a new initiative, and that initiative is the Make America Healthy Again initiative. And two of the bullets in that initiative, I think, play critical importance to you. And that is, number one, ensure that treatment options and healthy coverage flexibility for beneficial lifestyles and changes in disease, right? And that's those disease states that I talked about in that train. We think about the opioid crisis, but we have to think about the opioid crisis in the context of a syndemic. So that's hepatitis C, HIV, the impact of long-term substance use disorder on behavioral and mental health paradigms. So I think you really brought it up. What is the role, for example, of those behavioral health providers, buprenorphine, Suboxone, and methadone providers? There's an intersectionality there that I think we're going to talk about, particularly in your strategic planning. The utilizations of community health workers, how do those play a role? How do you make sure that Main Street is healthy? If Main Street's healthy, America's healthy. And I think that that's the work that you're going to be talking about here, about what we've been thinking about. The other piece of this plan that the President put out yesterday is declare the opioid crisis a nationwide public health emergency and sign the Support for Patients and Communities Act, the largest ever legislative effort to address the drug crisis in our nation's history. So what do we have? I think we have one of the most unique opportunities to blend federal policy, preparing for how do we be more efficient with federal resources, with the resources that we have here in North Carolina, but being able to do that through an implementation strategy that I think we're going to talk about overall. And I would say Wilkes County is the county you want to look at because it's done more with less. And I'll let you go on.
Okay. So first of all, I think I need to address the elephant in the room. This is the first presentation that I've given since I eloped. So you guys outed me to all of my friends and family, and I've answered questions about, did you get married for the last 3 days? So the good news for you all is Samuels is a lot easier to say than Barnado, but still the same person. So first of all, I'm going to give you a little bit of update about the strategic planning process, and then we'll go into some of the evaluation for efficient opioid settlement management that we've done across the state. So the strategic planning process, the collaborative strategic planning process requires steps A through N of Exhibit C in the MOA that Nidhi was talking about. So where we are now is we've completed A through E in like phase 1 is what we'll call it for the strategic planning process. And so a question that you all that are new might have is, why are we doing this collaborative strategic planning process? So this process brings together all stakeholders to the table to identify priorities and to create a long-term spending plan that also unlocks options from Exhibit B, which are expanded options for prevention, treatment options, leadership planning and coordination, training and workforce development, and research. So it really allows you to have a bigger menu to choose from when you're thinking about the priorities and needs of the county. And so these completed activities, A through E, are what I'd like to call the information and evaluation phase. So this is the part of the process where we bring the stakeholders to the table, we collect the data and information across the county that is specific to the county, and then we move into the second phase, which would be deciding on those priorities and deciding on that long-term strategic plan. So this information gathering and evaluation stage is complete, and we're ready to move on to the next steps. And so you can see the activities F through N here really require decisions. They require you all to make decisions, decide on collectively what are the long-term strategies that you want to approve funding for, and what strategies in Exhibit A and Exhibit B. It also builds in an infrastructure for reporting and transparency for what data you want to collect on each strategy, and so that's reported back to NC Core and published on their website so that the public can go on and see, and then you're invested and involved in the process, and you understand and have a good understanding of why those priorities were selected and what the results we're looking for are. So one of the things that we were looking at is, where is Burke County compared to other counties? And so we ran an analysis from Nidhi's great NC Core website, has so much useful information on there. And we looked at comparison counties. So which counties are comparable in total amount of opioid settlement funding? That was our first filter. And then we looked at population and approved strategies. So the counties that have the most similar amount of opioid settlement funding are Catawba, Brunswick, and Wilkes. But where you'll see a big difference is the population. And this comes from the calculation of how opioid settlement funds were distributed. So and Nidhi, you'll have to correct me if I need to add anything to this. It wasn't based on population, it was based on number of prescriptions and overdose fatalities. So that's why you're seeing, what's the third one? Oh, and population. Okay, so population is a factor in there, but the primary factor of that calculation was around the number of prescriptions and overdose deaths. And that's why you see the big difference in the population between Burke, Wilkes, Catawba, and Brunswick. So even though it was a factor in there, it was most likely the third filter, right? Okay. So what's interesting about this slide is we're looking at total amount of overdose settlement funding and approved strategies here. So when we looked at those 2023 approved strategies, that was the 2024 report on 2023 strategies. So it's still showing Burke listed as 2, even though more strategies have been approved since then. But what we're really looking at here is efficiency in decision making. So you can see Wilkes has the lowest population and was able to approve the most strategies in the first couple of years that we started receiving opioid settlement funding. And so the next part of our evaluation was we did a huge data pull from NC Core to look at the different models of opioid settlement management, to look and see if there was an association between approved strategies and overdose fatalities. And then we also did a survey to all of the statewide coordinators, and we did some key informant interviews. So the data analysis, we looked at all 100 counties and 14 municipalities that were receiving opioid settlement funds. And what we found was that there wasn't an association between overdose fatality change and number of strategies. So what that was leading us to find is that some of the activities that the coordinators may be doing around stigma reduction, network building, systems building, may have had a bigger impact than, at this point, the actual strategies. So this early in the game, we had strategies that were approved, but not necessarily implemented yet. So the underlying factor here is that while we were doing this work, we were also building community networks, looking at systems change, working with local leadership to change that culture around overdose and opioid use disorder. And so the survey, we had 26 people respond. The majority of the people that responded were from health departments, and they had an average of 1 dedicated staff member. And so we're really looking at like a strengths-based approach of like what's working well for you. They rated their management as very effective. Their top success factor was raising awareness about available funding and collaborating with stakeholders. And their top challenge was around data collection and evaluation. And so their suggested needs for improvement were best practices for the RFA process that Nidhi was talking about, and evidence-based training programs tailored to specific populations. And so with the key informant interviews, we talked to 3 different coordinators, and each one of these coordinators had been, had switched departments. So we had some that started off in the county manager's department. We had some that started in the health department and had experience working with one or more department. So we wanted to look at their insight into what was working well for them, what worked, what made the process the most efficient. And so the themes that we found from doing these key informant interviews were establishing clear governance structure, implement sustainable funding strategies, leverage data for strategic decision-making, and strengthen cross-sector collaboration. So the most common theme that we found when we were doing these interviews is communication. The coordinators that had the most access to communication from the community and to leadership reported the most success or feeling of productivity in their work. So some of the strategies that we pulled from all 3 of these different data collection measures. And so I'm going to back up just a little bit and say when we first ran the analysis, we looked at where the categories of management were, and 60% of those were in the county manager's office and 32% were in the health department. And some of the work that was being done, particularly out of the county manager's office, had external partners like Wilkes Recovery is a big one, since we mentioned Wilkes in the slide. So enhanced oversight and management efficiency, and this speaks back to that communication and transparency, establishing clear and direct lines of communication from the community all the way up to the leadership, and then the leadership engagement in the process. Standardized policies and procedures, so you do have that clear pathway of decision-making, and this is really important, and from my experience, it was something that was really necessary when you're working with multiple departments. So if you're doing work that crosses multiple departments, you can't just follow one agency's policy and procedure or one department's policy and procedure. That P&P has to cross over so that everybody understands the contracting process, understands the hiring process, and things like that you wouldn't think of as necessary to this position but are really vital. And then developing the infrastructure to support the capacity if you want to grow the programs. Like, what does that look like for the future? Do you want to grow the personnel that you're using? Do you want to extend to contractors? And then other funding streams, as we're looking at funding streams that are coming down federally and will likely be able to be braided with opioid settlement funding. What does that look like, and what are the processes in place to make that efficient? And so the next steps are building efficient decision-making systems so that we can move forward with the strategic planning process, and then aligning that strategic planning process with the county's fiscal year, so that when you're making those decisions about the long-term spending, it lines up with your natural budget process, and that way you're approving your strategic plan and your long-term plan at once instead of piecemealing it. And then the middle piece there that I skipped was coming together and being involved in the strategic plan process so that you are informed and you have some influence over what those priorities and strategies look like. And so, do you guys have any questions? All right, thank you for your assistance, Nidhi. But thank you.
All right, gentlemen, any questions? All right, we're going to move on to what are we working on now? This is going to come from our health department, our health director, Mr. Scalise. Good morning, Danny.
Morning, Commissioners. That. So Nidhi gave you some history, but I thought we'd go a little further back and start with, in 1998, the tobacco settlement. So what we're learning from is we learned from the tobacco settlement. A lot of the things that were started then, and North Carolina was considered an outcast in that. The state of North Carolina funded the Tobacco Farm Life Museum with tobacco settlement funding. And people in the public health realm were very upset at that. They didn't think that that was a proper use. They thought this was a chance for us to work on a chronic disease that was killing Americans. Now if you fast forward to the settlement that Nidhi talked to you about, we learned a lot from that. And I think the Attorney General at the time understood that and knew, and that's why we have this option A and option B. It's not like it was with the tobacco settlement where states were just given a large chunk of money to spend as they saw fit. So there are certain things that you can do within the confines of this settlement. And I think what's unique about North Carolina is in Georgia, West Virginia, and Ohio, for instance, they created a foundation where that money went. And if we wanted to use most of the money, we'd have to apply to that foundation and show cause. We don't have to do that here in Burke County. We got this chunk of money that we can use as we see fit. And it's at the discretion of you, the commissioners. And to show you kind of where we got started with this, I was hired in 2021. And at that point, I was getting to know the then county manager, Brian Steen, and he asked me a lot of questions about substance use disorder. I've worked in this space a long time as a public health professional. I understood it and gave him what I thought was good advice. Brian asked me to come to a meeting. I was here in this room, and I'm a social scientist by nature, public health is. So I asked a lot of questions, I'm a very curious person, and I saw things that weren't exactly the best practice. And I talked to Commissioner Carswell at the time. He seemed to be the person that had the vision for this is where we're going to go to tackle this problem. And this wasn't a talk about how do we spend opioid settlement money. This was a talk about we have a problem with substance use disorder. And as I understood what Commissioner Carswell told me he was thinking of, and what I was hearing in that meeting, I asked a lot of questions. And there was a gentleman sitting to my side. I didn't know him. I was still new here, and it was Hugh Blackwell. So he was very pleasant to me, nice, whatever. And I guess he called Johnny shortly afterward and said, "Who's this crazy health director you got asking a lot of questions?" So if you fast forward a little bit, a couple of the commissioners, we had a meeting in this room in March of 2022. Corey Fisher-Wellman was here with me and a couple of the commissioners that Kay had set up to kind of discuss that. And they asked us a lot of questions. Corey and I seemed to at least be able to BS our way to know what we were talking about. At least that's what they thought. And they said, "Hey, we want you to kind of run with this. We're going to get this settlement money. Do you know what we're talking about?" And I did. I was aware of it. I was aware of settlements across the country, even though I was new to North Carolina. And at that time, the NCACC was the one who was putting a lot of the packaging together. Nidhi and I had worked on a grant when she was at Duke before that. So we had a connection together. So it was very organic how we were able to learn kind of what it was that we did. Because of that, we later created what became the B Corps group. And we started with, who do we need in the room to talk about this issue of substance use disorder? We still didn't get into how do we spend the money. We thought that would come later. We wanted to say, who do we need in the room? Who are Burke County's experts? I'm happy to say that some of those people are in the room right now. Dr. Seichert is here. Corey is here. I'm looking out. There's Paul is here. Ashley is here. So we had these people who were the experts in some part of the field. We had psychiatrists. It sounded good. Thought I was being played off like in the Oscars when they. So we started that group, and we started to talk about how do we solve this problem. And it was very incumbent on me to be a good steward of our money. So there's been a lot of talk about how we haven't done as much with the funding. And you just saw Dr. Samuels. I'll have to get used to that, Kate. Congratulations. Dr. Samuels showed that we had 2 strategies, but we still saw a downward turn. And because of that stewardship, we started working on grants. We didn't start with opioid settlement money. Grants have expiration dates. This opioid settlement money is at your discretion. You can sit on it as long as you see fit as the commission. So as a result of that, we were able to get about $1.7 million in grants that we've been working on for a lot of the strategies that would come from Option A. Our goal was to spend those grants because they had that expiration date first, and we wanted to use the funds wisely. We wanted to make sure we created a sustainable thing. Because at first, when we started talking about it, people wanted to spend the money, but it didn't have sustainability. They wanted to spend the money, and when it ran out, we were like, man, we're done. In the 19th year, I didn't think I could look at a woman whose son died of an overdose and go, our settlement funding was only 18 years. So we tried to create a system that would work, that didn't have government doing things. It had government supporting people who did things, and created a system where they could do things like bill Medicaid for services or other insurance, or work within an opportunity to use that funding to leverage grants. And as the grant funds begin to matriculate, in conjunction with the Recovery Court Judge, Judge Keenert, we created a spending plan that was one resolution that didn't make it to you all. This was about the time that we had a change in health department governance, and Dr. Samuels left, and we were asked to pause. But I wanted you to know that we had, it never made it to you all, we had a Option A strategies list that would have been $1,036,110. That group was recommending to you to do expanding treatment services and capacity, having a systems coordinator, funding the jail MAT program, funding Recovery Court as their grant was ending, hiring a peer navigator, and funding a post-overdose response team with EMS. So those were strategies that we put on hold and put on pause, and I think you'll see if you create this group and throw those back at them, they're going to come back to you and tell you these are good ideas. So, but the point of me being here is to tell you prior to the pause what we were working on. We created a number of strategies. Some were at low cost or no cost. Some were under these grants, which is why we haven't spent as much of the money. So we started the OFR FAST team. Commissioner Barrier, you've got a good crash course here recently on the Child Fatality Review team. That was what we modeled it after. So when we created the Opioid Fatality Review Public Health and Safety team, OFR FAST is a little easier to say, and it's still in a developing stage. It's the first of its kind in North Carolina, one of the first maybe in the country of its kind. There are other opioid fatality reviews, but not that have the breadth and width that this one has. And it's got the Public Health Department, Social Services, UNC Blue Ridge, Burke County Community, paramedic, physicians, law enforcement, Olive Branch, High Country Community Health, and others. And the function of this group is to review overdose deaths, look for patterns, and then advise and recommend policies that could prevent those deaths in the future so that we don't make the same mistake twice. We started a group called PPE, Peers Partnering for Excellence. It's one of the first in the region. I think the only one that's even similar to it is in Johnson City, Tennessee. It's a professional group for peer support to gather and share information, network, provide opportunities for professional development. And you just heard how important peers are in this process. One of the problems we have is we don't have a lot of peers. And because as a profession, they're relatively new. People have been physicians for thousands of years, but peers haven't had that peer support. We're trying to create a network of those people who can work in this environment and give them a level of professional development and find the training for the people who come into this and want to be part of that. The Western Regional Partnership. You're going to hear more coming soon from the Fletcher Group. Fletcher Group Incorporated was started by then Governor Ernie Fletcher. Ernie was a 3-time congressman and governor of Kentucky, and he was a physician before he went into public office, started the Fletcher Group because he saw substance use disorders, one of the things that he wanted to continue working after he was no longer in public office. So with funding from the Dogwood Health Trust, we contracted with them to evaluate and strengthen the recovery ecosystem across multiple counties. We realized that this disease doesn't recognize the artificial boundary that is Burke County. Our problem, if we solved our problem in its entirety, but Catawba and Caldwell did nothing, we would still have a problem. It would make its way and seep its way into it. So they've evaluated and strengthened the recovery ecosystem across multiple counties. They've completed their data collection on substance use disorder recovery services. When they looked at counties around us, Alexander, Avery, us, Caldwell, Catawba, Cleveland, Henderson, Lincoln, McDowell, Rutherford, and Wilkes counties. And the effort included research, national, state, and local sources, as well as in-person listening sessions with county officials, organizations to identify needs, strengths, and gaps in recovery services. And based on that, they're developing a detailed report outlining regional assets and solutions to address service gaps with a projected completion date of April Fool's Day. I don't know if that's a good day or not. Maybe I should tell them to make it April 2nd. But planning documents included a business case plan and a project charter that will follow around May 1st. Additionally, they're working on a regional resource inventory system, and they expect that by the end of the fiscal year. And to foster collaboration, they want to create they call it WRAP, W-R-A-P, Western Regional Action Partnership. And they established that in July of 2024. It's meeting monthly, and ongoing efforts to focus on building formalized partnerships and culminating in the development of MOAs sometime in the fiscal year. Opioid settlement planning, for us to be able to do option B strategies. Not that we were thinking we needed to move into that, but we needed the option to be able to do it. The first phase of that was strategic planning. You just heard from CEG. We hired them last year to be able to do that, and they're in the process of completing that. I think you'll hear more from them a lot coming forward. We created a website. We talk a lot about transparency and what we're doing. I think Brian showed one of the GIS maps. We have more that we're prepared to put out on this, and also to put information out for the public. You heard Dr. Samuel say that one of the things that we've been doing is educating people. We've been teaching them. They're learning more and more about this. We are doing a lot of strategies that are low cost, high impact. A website was very inexpensive. We developed most of it either with our in-house staff or with Scott Black is in the back. I can barely see him through the window, but Scott's team's been very helpful with that. We created a videography project. It's an educational video that has a translation in Spanish that we'll be using. School naloxone training. When I was in school, there were a couple of kids that talked about smoking pot, and a couple of kids could get a beer, but I don't recall seeing heroin, much less fentanyl, in the school system. But nowadays, it's becoming more and more common. We've started working with the school system to develop naloxone training so that they can understand how to use it, what to look for. So we've worked with the staff as well as the faculty in the school system. Burke Recovery Court. Judge Keenert runs a great court, but administratively, that's a public health thing. We hold the grant and administratively manage the program for them. We support Judge Keenert and his team that's there. Ashley Jarrett's here. She can talk a little more about this if you have questions, but the Tropical Storm Helene seems like it's going to be a theme for everything we say for the next little bit. But it caused a bit of a crisis. Our team that works on this, because of the tropical storm, we collaborated with EMS, 911, Catawba Valley Health partners, and implemented a pilot project to bring behavioral health crisis response members to citizens in acute distress because of the trauma of Tropical Storm Helene. I don't think we've seen the end of that, and I don't think that we can just say, well, the storm's over, we need to move on. The B Corps coordination, this wasn't just a group that got together and had lunch. It included public health members, social services, the sheriff, the jail administrator. There were members of the faith-based community, leaders in the faith-based community, Morganton Public Safety. There was a private psychiatrist, Industrial Commons, the president of the community college, UNC Blue Ridge's leadership was part of it, Persons in Recovery, a local pharmacist, a local physician, and a treatment provider. And as we grew from a couple of folks that were sitting down talking about this issue, we created committees that worked on things, including treatment committee, a workforce development committee, data, faith and healing committee, and justice systems committee. So I think that group has slowed because of the pause that we've been asked to take, and we've not been able to replace the director of behavioral health. So that group hasn't really done a lot as of late, but I think the expertise that's there is unmatched by any group like that I've been a part of. We do public health evaluations. We're doing right now of our Harbor program and recovery court model. Public health evaluation, I like to tell people, we teach this to first-year MPH students that they need to evaluate the programs they have. An evaluation is having a third party. Think of it as in a basketball game, the guy who sits and keeps the scorebook. That's what the evaluation is. So naloxone vending machine, we received a grant from the Blue Cross Blue Shield Foundation, North Carolina, to fund us getting a naloxone vending machine that we will place somewhere here in the county. We've collected a great deal of data from participants in everything we do. We collect data for everything we do to see what we can see in terms of patterns, whether that's of medication that's gone this way, how the disease has progressed, or what we're seeing. Harm reduction, I'd be remiss if I didn't mention. Harm reduction is an Option A strategy. We haven't paid for any of it with opioid settlement funds. My friend Michelle Mathis is here. We use Olive Branch to do our harm reduction program. We've paid for that with grant money entirely since I've been here. Collaboration with Olive Branch to provide Hep C harm reduction services in the field. I want to make sure I get this right, so I asked Michelle to look this over and tell me if I got it right. Since working with our partners in Olive Branch, their programs responded, and they're responsible for curing over 200 people in Burke County with hepatitis C in the field, no necessary clinic visits, and curing over 200 people with Hep C, enrolled over 100 people into a Suboxone clinic with peer support follow-up, delivered thousands of test strips and naloxone kits to reduce overdose fatalities, and over 200 people in Burke County received post-overdose support and peer counseling because of the work that they've done with us here in Burke County. Those are things that don't get collected in the reports because we don't spend, as of right now, any of that money. We've not asked you for any of that money to go over to do that. We've found other revenue sources to be able to do so. Many of you have attended the community forums we've done. This has been a great way for us to get information out about the issue and to talk directly to the public and to give them a chance to talk back to us, to tell us what they're seeing, what they're hearing. We were able to bring state and national leaders with different perspectives to educate the community and permit community members to ask questions of those experts. Beth Macy, the best-selling author who's wrote multiple books on this issue. The North Carolina Institute of Medicine president, Dr. Kathy Colville, came. Dr. Stephen Lloyd, many of you got to meet, who is a physician expert in this country on this issue, also a person in recovery. The state health director came. NPR sent their national addiction correspondent. They're the only national news source I know that has one of those to cover it. The governor was here while he was sitting as Attorney General. And of course, the White House drug czar, Dr. Gupta, came. And in these forums, many of you got to come, you got to ask questions, and you got to hear straight from them and tell them exactly what we're seeing from here. And I think the last thing I want to mention before I take questions is, in conjunction with UNC Gillings, a grant was received, and we're in the planning process of creating a mental health collaboratory in Burke County. We're going to bring together diverse leaders and disciplines across the county to discuss issues surrounding mental health, with the inclusion of substance use disorder and ways we can strengthen the mental health system. We want to create a culture of transparent evaluation, accountability for all mental health programs across the county. And I think the thing that you guys need to grasp, if you don't grasp anything else that I say, is spending opioid money without talking about the mental health system is just spending money. Mental health this is a part of it, and it needs to be specific to the things that are in the settlement. But the mental health system and why people are using these substances is a mental health issue. And we need to start to tackle it that way, give some dignity to the patients that need it, and we want to create a system to do so. With that, are there any questions?
All right, thank you, Danny. Gentlemen, any questions for Danny at this point? A lot of good work going on. We can tell Danny's not passionate about any of that. Yeah. And Danny, appreciate that information.
Thank you.
This will bring us to a discussion of LME MCO capital grant, some funds that we've also been granted from the state, and our manager will tell us a little bit about that. Mr. Manager.
Thank you very much. I'll be brief, but in an attempt to continue building on much of the information, and I hope that the working session to this point has started off largely with a framing of, this idea that we have a lot of unique opportunity and resources, a lot of really tremendous work and foundation has been set. And the question now is, how do we again build these systems so that we can synchronize all of this information, all of this talent, all the programs and policies that have already been set in motion to generate the biggest and most impactful outcome that everybody's a part of, and we can ensure that all these different medians of knowledge and passion and all the tools we have are working in one unison. I think that's what's going to be unique about what the next few years looks like. To add to that conversation and to continue to build on these available tools that we need to leverage, we have a capital grant opportunity in partnership with Partners Behavioral Health, no pun intended there. So the first thing I'd like to say is just as a part of explanatory, what is an LME MCO? So North Carolina uses these local management entities for managed care to facilitate behavioral health care around the state. And even in the last 10 years, it is an ever-changing industry. I think Dr. Holden is here somewhere, or he was a few moments ago. There he is, who worked with Partners Behavioral Health, and certainly I've enjoyed getting to know him. But this is an ever-changing industry. What their work and what they've been asked to do by the General Assembly is ever-changing. Only 10 years ago, there were many more of these organizations than there are today, and there continues to be a required expansion of what they serve, who they serve, and what they do, and fewer and fewer of them that do it. But here in Burke County, the Secretary of Health and Human Services kind of defines these regions and who they serve, and largely they are a company that provides, an umbrella of service for mental health, developmental disability, substance use, and traumatic brain injury to people who largely have public insurance or no insurance. What's unique here in Burke County is, again, kind of building on what Mr. Scalise was talking about in this effort to facilitate grants and leverage funding that may not have the same parameters and compliance requirements as the opioid settlement dollars, and that don't kind of consume those one-time resources. We have two different grants. One that was received from the North Carolina General Assembly as a direct appropriation to Burke County in 2021 was about $3.25 million. And then this past year, a supplemental appropriation of $3 million. So as we sit here today, we have $6.25 million. It's a grant awarded to Partners Behavioral Health in a collaborative effort, but can be used on capital needs, brick and mortar needs, to help facilitate the realm of mental health, behavioral health, substance use disorder in Burke County. So the question is, what is the highest and best use of those resources? We know that, as Danny just kind of spoke about, the county did receive a Dogwood Trust Foundation. I think it was $275,000 to facilitate this ecological analysis, needs and gaps through the Fletcher Group. But we continually hear that there is a lack of providers, whether that's clinical, counselor, MAT, whatever it may be. And so, there's been this conversation around what's for folks who want to be in recovery, or for folks who are on their path, what is the best utilization of a way to help them achieve that? I'll give you an example. Recently, actually over the last maybe year and a half or so, as he mentioned, Judge Keenard and the judicial team have began administering recovery court, which seems to have incredible. It's Judge Elliott, Judge Keenard, and who's our third judge? Anybody remember? Barkley, that's correct. Thank you for saying that. I've attended recovery court graduation. The stories are just amazing. The data that I've seen is that about 70% of people who complete this course, 70%, are having regular, clean drug, passing drug screening, maintained employment, no recidivism at the judicial system. It is an overwhelmingly positive, evidence-based program that seems to be working well. The provider, however, and it's an intensive program. When you hear recovery court, it's really not a judicial process. It's a diversion program that offers clinical rehabilitation or recovery for folks who, contrary to going to jail. And when you hear recovery court, the intensity of what that is isn't necessarily communicated in the definition, but this is multiple days a week, multiple hours per day of counseling and other types of recovery processes. But the provider for Burke County is a company called Cognitive Connection that's in Hickory. And many of the folks who need that service have significant transportation barriers and challenges. And so, again, if they rely on public transportation, then maybe they have to leave at 8 o'clock to get to Hickory on Greenway, and they're there till 5 o'clock, even though their treatment's only 3 hours. It consumes their entire day. And when we talk to those folks, it's why are there not more providers here? The cost of space, the overhead of that is a real challenge. And not to get into a clinical economic discussion, because I'm certainly not the expert, but when you do talk to people who operate in this field, many times there's a challenge of doing what's best for the patient and the client versus what's billable under public insurance policy. And so, the cost of operating in this field is just really an economic challenge. And I think that's what this grant may give us the opportunity to deal with is if the Board of Commissioners sees value and if there's positive content around giving space or providing space in some way to providers so that they can largely have cost avoidance as it relates to a physical place to operate. That's one idea we've heard. Again, Dr. Holden is here. We've communicated with the executive team from Partners, certainly had lots of conversations internally. I think the terminology that I've heard Danny use is like a behavioral health urgent care, but what's been, again, all of this is open for discussion. I think that's the point of today, is that so that Partners can receive some feedback as they're delivering their scope of service back to the state, who is the grant agency, but Partners is receiving those funds. I'll briefly describe, an option, a concept that's certainly open for other feedback. But the idea is to provide a space at little to no cost for a variety, a spectrum of providers that can meet folks where they are and help align them with the path that may meet their needs. And that could be different for different folks. So even though my optic may be overly simplistic, the idea is if you have an encounter with law enforcement, or if you are just a family member that's in active addiction, or if you have, you show at the emergency room, wherever your interaction is, and you say, I'm ready for recovery. I'm someone who has, experienced an overdose reversal, and I'm safe, and whether I go to jail or I'm going to my primary care provider, or I just assess that I'm ready, what do I do next? Where do I go? And if the concept here is, whether it's behavioral health, depression, substance use disorder, whatever, you have one place in Burke County where you can go. There's people there that can meet you where you are, do some type of, maybe it's crisis detox to stabilize, and then there's the ability to assess, evaluate what your highest and best need is by a trained professional clinical person, and then have this idea of this ecological analysis from the Fletcher Group or some type of roadmap of what's available in this community and help align you with that. And if I've heard anything, and again, I may be the least experienced of some of the professionals that are operating in this industry in the room, but in my career, if I've heard one common theme, is that it's a very difficult system to navigate. There's often not a warm handoff between this service and that service. So think about this as kind of a triage where, again, no matter who approaches you and says, where do I start and how do I begin this recovery effort? You go here, and once you get there, you're in a safe space where someone can help, really address your root cause issues and get you onto a path to help you be successful. And I think down the road, lots of Option A strategies could fit in these outcomes as people get aligned with an option. And maybe that becomes a pipeline for supporting some of these providers with opioid settlement dollars to see if we can begin to make some type of impact. the point of today's discussion really is trying to develop, at least start a conversation about highest and best use with this one-time capital grant. It's from the state of North Carolina and the General Assembly. It's a little over $6.5 million, $6.25 million, $6,250,000. And it can be used for a variety of things, but brick and mortar capital is the general idea. So, Mr. Chairman, that's very short and brief, but I think we are looking at least for some direction so that partners can communicate further with the state.
All right, thank you, Mr. Manager. Gentlemen, any questions for the manager on this particular grant item? Yes, sir.
Brian, I just have a question about the use of that $6.2 million for capital. Does that mean that the county itself needs to own it, or is that something that a private entity, we leased it, we can fix their building up? Could the state possibly provide a building that's sitting empty, which they're all over Morganton?
Yes.
And lease it to us for $1 and we use the money to fix that building?
Yes. All of those options, based on my understanding, it can be used for any capital upfit, purchase, new construction, really any of those will classify. If there was a state building that the county could lease and use that money for upfit, I think that would be compliant. If the county wanted to build a space, buy a space, lease a space, I think all of that is compliant. I do think ultimately the county would own the facility and then enter into a long-term lease with probably partners. Right now Partners is the holder of the grant, but the idea is that they would oversee the providers that operate inside the building, because as our managed care organization, if there are providers in the community that will bill Medicaid, they're under their umbrella already. So all of those, if you think about the Rolodex providers, whether they're here now or we could recruit them in or they would relocate here, I think that they would operate under the I'm not going to call it supervision, but the context of our LME MCO. So the answer to all of your questions is yes, all of those would be good options.
Yes, sir.
Brian, what's options we have for the state with everything we've got at Broughton, all those facilities we have? I mean, can we not utilize some of those facilities like Brian was saying? Everything's kind of central there.
Sure.
I'm sure we probably looked at all those different options, but it just seems like, man, we got to utilize some of these buildings.
Certainly at this point, we haven't spent the time, evaluating specific places or opportunities. The idea was first, are we going to accept this one-time grant, and are we comfortable with this kind of idea of a centralized kind of integrated space for this one-stop kind of shop. I think that if we wanted to evaluate first adaptive reuse projects for existing facilities that may be state-owned, it's a great idea. I don't know the cost of upgrading some of those spaces or the conditions of some of the buildings that aren't being utilized, on the hospital campus. But that would, I think, be a conversation with the Health and Human Services Secretary about utilization, and then an evaluation of cost and long-term lease. I mean, I think we could get there, some of those mechanics and details. I haven't personally, and I don't think anybody on our team has said, hey, that building would work, or that building would work, or that space would work. Today was more about, do we see value in the framework?
Other questions? All right, seeing here none, what I'd like to do at this time, we've got, I think, some time we can do this. I'd like to ask Nettie and Katie and Mr. Manager just to kind of come back to the front and have just a few minutes of question answers. There may be some folks in the audience that have some question or that would like to pose a question, or we've got a little bit of time, I think, for comments before we get into our decision-making process. So at this time, I'd like to open the floor to questions. Of course, commissioners can ask questions as well, but I'd like to give the audience a moment to ask a question or present a comment if you'd like to do so. Yes, ma'am.
I work on this issue with employers throughout the country, some other counties as well, and I started this conversation today during the break. One of the major issues is the squeeze on primary care and the squeeze on the doctor-patient encounters, the national average of actual doctor-patient time in a primary care setting is 7 minutes. And you cannot solve for a lot of these problems in 7 minutes. But when a patient slash employee, I represent the employer community, that's the people that I help with healthcare costs. When an employer or employee is in pain and sitting in their doctor's office, they've already been asked by the CNA who brought them to the exam room, are you in pain today? Because they're required to ask that question. So there's the elephant in the room is somebody needs to solve this for this patient. But when you only have 7 minutes to spend with them, you cannot do it. So.
Excuse me, Chris. Scott, could you bring us a microphone possibly for the audience? I did not think about our YouTube folks cannot hear the question. I apologize.
I'm happy to reiterate that if I need to.
Yeah, if you can concise it a little bit and restate
Sure.
it, that would be great. So let's swap easier.
Okay. Suffice to say, investing in primary care and almost reforming the way that operates traditionally. Let's face it, primary care is just not that expensive. It really doesn't need to be insured. It's just not that expensive. Insurance is really for the catastrophic. So if you can change the payment mechanism in primary care to a flat, affordable, transparent, monthly stipend, then you take this problem of 7-minute appointments and you throw it right out the door. Because essentially before the employee or patient ever needs their doctor, they're already paid. It's a monthly membership recurring stipend. And then all of the time that has to be spent on billing and coding and prior authorizations and all of the nonsense that we have to deal with when insurance companies are involved, all of that gets recycled into focused on the patient. So in direct primary care, that's a new and emerging trend in the healthcare system where primary care doctors have said, you know what, I don't think I want to operate and I have to be reliant on insurance companies to reimburse me for the work that I do with my patients. I think I just want to set a transparent monthly membership fee and let that be my only revenue stream, and I'll spend all that extra time on patients. What we find in employer settings when we put direct primary care into the plan design of the health plan, we just embed that right in so that it's not some extra expense off to the side. It's part of the health plan's design. We see opioid prescribing plummet, and in a short period of time, and I have data from other case studies to show you. And I work with some other vendors. I got a couple of statistics while I was sitting here. Burke County is actually the 13th highest prescribing county in the state. And in the whole country, out of over 3,000 counties, we're number 241 in terms of the amount of prescribing that providers do in this country. So I would say that there are AI tools that do claims data analysis and help identify prescribers who maybe need to be just aware that they are high on the totem pole in terms of prescribing. And those tools are easy to access. So I would just say I'd love to know more about how these financial resources can be used in conjunction with what's already been brought up here, such as the use of existing structures that are already here, but maybe help fund a startup for a physician who's ready to exit the healthcare industrial complex and do things on a cash basis rather than having to do the unnecessary activity exercise of getting reimbursed by an insurance company for their time. So there's enough critical mass in this county to bring someone whose philosophy is like that and who just wants to care for patients. You know, I don't want to file insurance claims, I just want to help patients, right? So I think that we need an entity like that, and if there's money to help support bringing a startup like that to the county, I'd like to know more about that.
All right, thank you. Hugh, would you mind come help us with the microphone during this session? And ladies and gentlemen, that's kind of a broad question, hits a lot of areas. If you can give any response to that in terms of can these monies or facilities we're talking about, could any of that possibly, I'm sorry, Danny, I meant to call you also. Come on up with the group.
I believe Ms. Gupton makes an excellent point that primary care doesn't have enough time with it. I am a little worried, I'm not an attorney, we need to talk with an attorney, that wouldn't be something that would be qualified under opioid settlement funding. I don't disagree with her, the primary care system is not great, but I certainly wouldn't recommend that the next time that we go to develop our insurance program that we cut it completely out. Those direct primary care programs are emerging. They're not entirely new. I mean, if you think about it, it's the doc who does a house call. There's a few of us that are old enough to remember those around there. So I think it's something that's emerging. I just don't know if it's something county government can provide the support to do. Something we can certainly talk to our Representative Blackwell or Senator Daniel and say, hey, this is something maybe that you all should look at from the legislative standpoint. But without talking to an attorney, my interpretation of it would be that it would not be something that would be covered, and certainly not under option A, and I don't know that it would be under option B either. I think it's just too much of a stretch for us to use opioid settlement funds for that.
Any other thoughts on the panel?
Yeah, just emphasizing that appreciate that the healthcare system is complicated, that the payment models are complicated. We certainly need to reform multiple parts of it. And I'm hopeful that the opioid settlement money, like Danny said, will stay within sort of the people that are dying the most, at most risk for death from opioid use disorder, which I understand is at sort of a different point in the spectrum of pain management, very much a real experience for people, and also opioid use disorder and all of the places in between. So yes, it doesn't quite fit for the opioid settlement money, but it doesn't mean it's not a good idea and doesn't need to happen in other places.
Okay, thank you, Nettie. Any other comments? Okay, right here.
Well, just one quick comment on primary care. My name's Sam Sykert. I'm a general internist, so I know something about primary care. I have a lot of gray hair, you can see. And in working in some counties, rural counties in the eastern part of the state, federally qualified health centers and their primary care doctors have done a yeoman's job, both in terms of limiting their pain prescriptions that are opiates and in terms of actually treating opiate use disorders with Suboxone. And anyway, in those clinics, we did use some funds. They weren't opiate settlement funds. They happened to come from HRSA, but we would pay for social work counselors to support the work of the primary care physician so that the physician could do the prescribing and there was integrated care for the patient. And anyway, these programs have been very successful in terms of both number of patients and the success in treatment. So using money to support primary care to accomplish this, I think, is something that would fit under the opiate funds.
Mr. Chairman, I'd also point out, as it relates to the grant discussion, we do have an FQHC here in town that operates in this space, and I, from my understanding, does a pretty good job. So, having some type of primary care provided through an FQHC lens in the space would be a compliant source, because the grant, at least, and how the space is utilized, is not restrained by the parameters of the MOA.
Yeah, and the other thing is they also treat patients' other problems, hypertension, diabetes, hepatitis C, and there's no stigma to going there.
Yeah, and I want to emphasize, yes, primary care is absolutely needed. FQHCs all across the state are playing a role in opioid settlement program implementation. There are strategies in option A that say you can provide primary care for people with opioid use disorder or people who use drugs, with this idea that we want to wrap them around, like what is the root cause of their pain, or we know that building a building is really expensive, but integrating mental health or behavioral health or particularly opioid use disorder treatment within primary care is much more accessible. It should, you should be able to walk into your doctor and talk about your whole self, and not necessarily have those like separate, different place. And so opioid or office-based opioid treatment, or OBOT, is absolutely something that is available under the Option A for Option A strategy number 2, evidence-based addiction treatment. But it's just specifically for people with opioid use disorder on that sort of end of the spectrum. So I just want to differentiate that primary care is a setting you can operate in, but it just has to be for a population that's defined, not just general population.
Okay.
So I have a comment, maybe question, if you have an answer. So I was listening to Mr. Scalise and about the grant funding. So when I hear about all the groups that are kind of involved in that, what, as a community member, as a parent of an adult child who has an active addiction, what I'm hearing is that we're tapping into a menu that's available. We're not looking at necessarily what works, because clearly those do not work. We're not saving those lives. So I don't know why we're going back to the same menu. Why are we repeating the same choices if we want different results? So that's a real concern for me there. The second concern I have as the parent of a child who is an addict, who started out as a very 6-year-old being prescribed medications that are intended for adults by a local pediatrician who, at the time, I was told by them they had an interest in behavioral health. As a young mother, I didn't realize that having an interest and having the ability to treat were two different things, and that pediatrician over-medicated my child. Now that child is an adult with an addiction, because now we know that some of those drugs actually open the receptors in the brain, much like meth does. So I think that I have a parent of a child who's in his 30s, who's struggled with addiction for 18 years now. I'm not a medical expert, but I've lived that life to know that we have a system that doesn't work. In the school system, it was about that time that there was the big push, let's treat kids for ADHD, oppositional defiant, obsessive compulsive. We treated them with these drugs that we had no idea what it did to the pediatric brain. And now we have a generation that are addicts, and we're going right back to the same experts that screwed us over the first time to try to fix it. So I want to challenge you all to find real solutions, because the people it affects is me. It affects my neighbors. It affects my grandchild who's not with her parents. That's who it affects. So while everything you say sounds good, I've heard it for a lot of years, and frankly, there's just not the results there. It's just not. I appreciate it. I appreciate you looking, and it's a good starting place, but we need to be doing a whole lot more than what we're doing, because we're losing too many lives, and it's people who have potential, and it's because experts who thought they had an answer, who didn't know what they were doing. And I can go home and treat my child at home and get as good a results as what I have gotten by taking them to people that I paid lots of money to help. So please dig deeper than what you've done, because what you've done and what you've uncovered is not a solution to this problem.
Okay, any comments from the panelists? Anybody want to speak to any of that? It wasn't exactly a question, but some direction.
I feel like and hear your heartbreak, and I hope that your son stays safe. I can appreciate and understand and agree that we need to do more, and we need to do a much more comprehensive approach than we've been able to do so far. I'm hopeful that the opioid settlement funds will offer us a chance to really take a comprehensive approach. No one thing is going to work, no one little bit here, one little bit there, but we really do need to do our best to try to take a look at the whole picture. How do we support people from young age all the way through adulthood? We're all broken people who are trying to do our best. And how do we do our best to wrap ourselves up in love and support from all different places? And I know you've been trying your best and trying your hardest, and I think that I'm feeling hopeful that this is going to give us a chance to really dig in and look at things deeply and say, well, it hasn't been working, what's not working, how can we try it differently? How can we learn from lessons of the past? How can we learn from people who are living it, who have been telling us for decades what works and where our systems have failed them? And so I'm hopeful that our ears are open, our hearts are open, and that we can use our heads to do something a little bit different. And so whether that means working across systems, trying to integrate services so no one gets lost in the spaces in between, or just doing our best to listen to the people that are living it and take that to heart. So like, how do we listen to people who are living with substance use disorder, opioid use disorder, using drugs, who can tell us, well, this is not working for me. What can you do to do better? And really trying to focus in on that. So like, I hear your heartbreak. I feel it with you. And I'm hopeful for the best.
And I appreciate that, I truly do. I just look at that total amount that we're getting, and that breaks down to about $1.5 million a year. That's not a tip of an iceberg of what it's going to take. That might pay for the administrative cost of what you're talking about, but that money is not going to go to that addict because it's going to be used to pay for the people. Now, you might bill insurances. You may bill insurance or Medicaid to help cover those costs, but there again, we're going back to some of those same people who are the culprits behind the problem. So it's like going to the fox who's just killed all the chickens to say, can you help us revive these chickens? Well, no thanks, you've already killed them. So please, I hear what you're saying, and it's not about heartbreak, it's about being fed up. It's about having our money squandered and wasted by people who don't have a clue what they are doing.
Tony, I sense you might want to speak to this just a bit.
I do a bit, because I agree with you that it's a systems issue, and I think a bit of it is certainly the individual issue, but I think that's what we've been trying to assess, right? Is that there are pockets to this. There's the individual, there's the community, there's the local and county government, there's the state government, there's the federal government. And I think that's why I wanted to talk about the idea of what does efficiency look like. You're right, it's like $1 million over 18 years, right? So, I mean, but if you look at it solely that way, then you only look at the $1 million. We can't necessarily just look at the one individual. We have to look at the totality of the problem. That's why I like to really talk about this from what we call a syndemic approach, right? What's going on with substance use disorder, what's going on with, as Danny mentioned, the behavioral health challenges that we see, but also then what's going on with local county government, what's going on with the state government, and then what's going on at the feds. So what do we know? Yesterday we got some really, I think, good news, is that the opioid crisis is a #1 priority for the White House. Okay, great. So that's thing one. Thing two is what we know is that we've got these resources from the opioid settlement, which are way more flexible and out of the control of the federal government. What do we know? That the government is looking for efficiencies. What are the way in which we can use federal dollars or state dollars, or in this case, opioid settlement dollars, to leverage other dollars? And I think that's what Brian is asking us to do. Is can we take those dollars that we're going to get for making this system approach, right? Building a new warehouse, taking a warehouse and turning it into a workforce development center, taking a warehouse and turning it to a place where we can triage individuals that are coming in. How do we do that? How do we do that in the most effective manner? The thing is that we've been dealing with this opioid crisis for 30 years, right? We finally have a resource. We finally have tools that we can do. Everybody did it bad. Everybody did it bad. Everybody is now trying to figure out what's the most effective solution, not for just your son, but for your daughter, my son, and everybody else's too. So we have to figure out a plan that is going to let us do this network. I think the idea of being able to have a one-stop shop, maybe if your person can walk through a door and I can get my workforce training, I can get my behavioral health. Maybe if I got a job, and maybe if I got behavioral health opportunities, maybe my substance use disorder link is a different thing,
right? Because I think that that's what we got to think about, is that it's the whole person solution that we have to come up with. That's going to be the tough job for this group of people, is that they have to devise a plan that meets everybody's need. It's got also devise a plan that has an impact on Main Street. They've got to devise a plan that is also going to impact the tax base. So that $1 million, they got to figure out how to turn that 1 into 5. And the only way you kind of get to do that is that you have a solution that includes everybody, the community, the local and county government, and the tax base. Because the tax base feels like they've been taking it over the head too, right? They feel like they've been paying for something that wasn't necessarily their problem. So they've got to figure out that part of it too, and that's where the efficiencies come in. Can we create a workforce? Can we create a tax base? And then can we devise solutions that allow us to generate income for the county? How do we do that? And we have to do that, honestly, a step at a time, partially with Part A, partially with Part B, but like you said, I think we got to look at it in a broader solution. I'm sorry I rattled on so long.
That's okay. That's okay. We'll take one more comment, then we're going to move on to just.
Thank you. First of all, I'd just like to say thank you to everyone that's here, commissioners, Brian, county manager, and Danny, Katie, everyone, Doc. It goes without saying that everyone is about this work and everyone understands that there's something that has to be done, but I hear the concern about primary care. I hear the concern about your son. I've been living in this space since 2010, in the space of recovery, in the space of treatment, in the space of addiction, in the space of addicted individuals. And I have been a part of some great things in those times. I've been able to build programs. I've been able to be a part of people recovering. And I understand that it takes a lot. At the core of addiction, you'll find isolation, you'll find selfishness, you'll find self-centeredness. You'll find some issues that indicate that there's more than a behavioral health problem, that there's more than a physical problem, that there's more than a mental health problem. There's a spiritual problem as well. And a lot of times what we need is a place where addicts and alcoholics or people that use substances can go to recover. So you are right. It does start with Narcan saturation. That's wonderful, but that is not the solution. You got EMS out here who is drowning. I don't know if she can say it, but I can. She's one. We don't have a port team here. I can tell you where all the overdoses are. I can tell you where the majority of them are. You already know. You know that North Carolina sits at a geographical disadvantage with the corridors that run through it. We understand this. But it's not, in my opinion, necessary to create task force and coalitions and new committees to identify this. You have a community that's been living it for a long time. You do. You don't need to reinvent the wheel. You have MAT providers in this community. We have a residential treatment program for men. I've got a long-term residential treatment program. There's a model that is scalable. There is a model that can be self-sustainable, that can generate its own revenue, that can live after the life of grants, that encompasses all of this. That's what I want to be known, is that you guys need to hear that. Because your concerns are right. There's a distrust from the public with healthcare. Does anybody know how much of a curriculum is spent on a board-certified doctor in the area of pain management? Dan?
Pain management?
Yeah, how much of their curriculum is spent?
In their third or fourth year, there'd be somewhere between, it's built into internal medicine residency, some in their third and fourth year, some in their, Dr. Sykert, do you? I mean, it's scattered throughout now, but.
A lot more is spent now than was 10 years ago.
And 30 years ago, we didn't even include mental health in this. Now we have co-occurring disease. Now we have dual diagnosis. Like, we are making progress, but the answer is less than 10% in the area of substance abuse, the area of pain management. So it's no wonder that we're prescribing medications at a clip that's killing our youth. That's a concern. I would love to be in this community. My wife and I have children in this community. We provide services for the children in this community throughout the school systems. I hear your story, and your son needs somewhere to go where he can be around like-minded individuals, where he can focus on himself. And there's a way to do it. There's a way to include workforce development. There's a way to include harm reduction. There's a way to include prevention. There's a way to include education. There's a way to include the whole individual.
a complete recovery ecosystem. And you don't need to shop that out. You need to come to us because we know what we're doing.
All right, thank you very much. This time I'm going to give us a 7-minute break, and then we're going to come back and get into our decision time. Okay? Thank you very much. Great discussion. All right, we'll consider ourselves seated back. And again, thank you for all the discussions and comments during that time frame. I know we could spend hours and hours and days discussing this, and all the folks that have presented and have worked in this area for years and years understand and continue to want to hear what you have to say. So this brings us to a time of discussion and direction. And gentlemen, I think basically we have three areas of decision we need to consider this morning. One being the direction of our leader going forward. Second being the direction of these grant funds that we've just spoke to just a little bit. And then to memorialize our opioid advisory committee. We have, of course, had a committee that was formed as, I believe, maybe it was Danny or Mr. Manager, one of our panelists described how that was put together initially. That committee has done a great job. However, the memorandum of understanding requires that we, I think, memorialize that group so that it is clear that we have a group that the commission has approved. So we want to do that today as well. We have opened that committee for applicants, of course, asking those that have been serving to apply and any others that wish to apply. We've got many applicants for that, so we'll consider that item last. I'd like for us at this time to consider and have discussion as necessary the item of where we place the director of this operation. In the past, Katie has served in that role, as we have talked about, done a great job. We've accomplished a lot of things. We've seen those accomplishments this morning in the program. And so with her departure, it was an opportunity for us to take a step back, see where we are, look at all this data that we've looked at this morning, think about the best ways for us to move forward. And so that position in the past has been under our health department. We've heard alternative positions. So many other counties has this person to take more of a departmental role and working directly, in the manager's under his purview in terms with all the other county department heads. We've, I think in the past, correct me if I'm wrong, Brian, we had this director on a 1-year, 2-year basis.
It was 2 years, funded from July of 23 through July of 25. Yes, sir.
And of course, this position is funded through the opioid settlement funds. And so we can consider that position longer term if we desire today. 3 years, 5 years, whatever the board may think appropriate. This, as we've heard, is a long-term mission. So I think we should consider enough time for that person to have time to work and not make that too short. So at this time, I'll open the floor to the commission to hear comments on how you feel we need to move with this position in terms of its reporting space or its length.
Is this just a discussion, Mr. Chairman?
We're discussion and then decision.
Well, my personal opinion is that we do need this position. We need somebody focused, as we did have with Dr. Varnado. I think it should report to the county manager. I think we need to move quickly. We've had some of you know, I had a Facebook group discussion Some people think that's funny. I don't think it's funny. I think we had a wide array of community members reach out through that, and we do have in our packet some of that, or the entire discussion. What I really realized from that is urgency from the community. And so although I do appreciate coming from a corporate environment in the past, how strategic planning is important, sometimes I think we can have analysis to paralysis where we're just not really putting our feet on the floor and moving in critical ways. And I think these funds allow in its framework to make that happen. And so I think that's best suited to be managed on an ongoing daily basis. So that's what I'd like to offer there. Thank you.
All right, thank you, Commissioner Berry. Other thoughts, comments on the position where it reports and timeline?
Mr. Chairman, I would like to concur with Commissioner Berry. I think the importance of this issue really deserves the most direct path that it can to this board and this body for decision making. And I do think that reporting should go through the county manager.
Other comments? Does the board feel that a 5-year timeline would be appropriate? Any comment on that?
Mr. Chairman, I'd like to see the 3-year, see where everything's going, and then from there proceed on.
A comment? All right, hearing none, I would entertain a motion at this time on this particular item.
Mr. Chairman, I would like to make a motion that we do fund the position to lead this group for a period of 3 years.
Thank you, Mr. Barrett. You've heard the motion. That includes, I think, for this position to report through the county manager's office. Is that right, Mr. Barrett?
Yes, that's correct, Mr. Chairman. Report through the county manager's office for a period of 3 years.
All right. Gentlemen, you've heard the motion. All those in favor signify by the uplifted hand. That is 5-0, Madam Clerk. All right, that brings us to the grant funding that we've received through the state. And of course, just to give a little bit of background here for folks that have followed this item along, initially we were hopeful that we might be able to use our existing old county jail. But as we dug into that, the cost of that rehab was just simply not feasible. Also began to have concerns about location, but here we're talking about money in particular with the 6.25 that we had. Seeing that certainly wasn't going to work at that location, I think we have partnered with partners, our LME MCO group, and we appreciate all the work that they do for us all the time. And so they are looking for some direction. You've heard a potential method of doing that with putting those funds together, looking for a facility, build a facility, a number of ways that can happen. But I think just in general, partners would like for us to say, yes, that's a good idea. Paul, please correct me if I'm getting out of bounds. They would like to know that we're good with that approach, and then they will begin moving this forward as quickly as they can. And of course, we'll be providing some input in that along the way. So gentlemen, any more discussion on that? If so, we're glad to hear it. If not, I'll be glad to hear a motion.
Mr. Chairman, can we define a little more clearly what the path forward is? Are we talking about making an investment in capital with partners, or are we looking at trying to partner with another agency to provide space for partners?
So if I make this, at this point, partners has to give the state Department of Health and Human Services kind of a broad scope that the county commissioners and partners, executive team and their board agree on. So the idea of this one-stop shop, this triage, this idea of a multitude of different providers, everything from crisis detox through occupational rehab being, you know, you go here to start, is really where the conversation is. The $6.25 million can be, again, a partner's grant, but shared kind of vision between the county and their agency to build, buy, lease space. Ultimately, they would be the manager of the building and help facilitate the people who provide services inside the building, because as the LME MCO, folks who bill public insurance, Medicaid, and certainly even their providers can bill private insurance, but all of the public side would go through their kind of lens. So we as staff would work with partners to bring a more detailed proposition back about where it is it new construction, is it rehabilitation on the existing building, what services go in there. That would be, you know, hopefully sooner than later, 60 to 90 days down the road. But at this point, it's more about are we, as the Board of Commissioners, supportive of utilizing this one-time money in a way that provides brick and mortar space as a kind of a urgent care model, if you will, of behavioral health needs in Burke County.
Mr. Manager, when all is said and done, is the county gonna maintain possession of this brick and mortar location, or who's gonna have the control of it?
Yeah, so the county would own the building, the title. Part would likely lease it through a long-term lease to partners to manage, who would then facilitate which providers, you know, come in, whether that's counseling or clinical provisions or you know, whatever. But ultimately, I think there's enough uncertainty in the future of LMCO models that the title would remain with the county. I don't know that I fully answered Commissioner Burns' question. No county money in this. It would be whatever plan comes up for would be at or below this grant amount.
And I concur with some of the other commissioners about using existing buildings, but I'm gonna throw another option out there. If we're gonna invest money in a building in Burke County, I'd prefer to use a vacant public school building. That way, when all is said and done, our public schools can go in and use it instead of putting it somewhere at Broughton that they'll never use it again.
Other comments to your point, Mr. Smith? I think we're not quite there yet, but we'll work to figure that out. We do have, correct me on the date, I'm thinking end of February, to give the state a yes, you know, here's what we're going to do to make some broad statement to them to keep our grant funding alive. So that's kind of where we are with that.
So I just want to state, just to be really clear, the grant is Partners has secured the grant in partnership with the county to provide space. That's correct. So it's a Partners grant back. So then tell me how we would end up owning the space. Is it through that agreement?
Yeah, yes.
Okay.
And I guess if you looked at it maybe 30 years down the road, you know, that the building may be used for something else, we may, you know, this thing could change a whole lot in 18, 20, 25 years. But right now we're talking about this specific amount of money and how it can be allocated at this time.
So today we're just going to take action to accept the grant in partnership.
It's really to provide direction to partners to finish their scope of work to submit to the state. And I think that would look as simple as either Mr. Chairman could facilitate a vote, or it could just be conversation and direction through our office and through partners to just, you know, largely describe what we've talked about today and endorse that as an option that the board is interested in.
So going forward, could we not just simply take a vote empowering county manager's office and staff to pursue this, or?
If that's what you wish to do, certainly you could, yeah.
Other comments, questions? All right, with that, I'd like, of course, then I'll propose a motion that we give partners direction to advise the state that we are comfortable with this approach, an approach that would give them direction to look at how best to use those funds, whether it's rehab, construction, and bring that back to us once they reach that conclusion. I'll make that as a motion. All in favor signify by the uplifted hand. 5-0. All right, does that seem to give you the direction you need, Paul and Brian? Okay, thank you very much. All right, that brings us to our last item of decision. And gentlemen, let me ask you to refer to, you've got a large packet stapled together in front of you. And on this, actually, I guess it'd be the third page, if you count the back page of the first page.
Excuse me, Mr. Chairman?
Yes.
Did we need to discuss option A versus option B strategies? Is that a subject we want to close down today until our advisory committee has maybe a chance to confer? I know in the past, I think we had some general idea. We were working in the A space, and then we were kind of waiting till things were in such a direction that we could, if we so desired, wanted to move to the B space. Do we want to confirm that direction at this time? Or are we good as we have been moving? I guess since we're essentially bringing on a new director and a new group, maybe it would be best if we did give that clear direction, a more clear direction. What's your thoughts?
Or if there's, Nitty and her team, I thought, did an excellent job going through the 12 strategies of Exhibit A in detail. So if there was any particular strategy that a board member wanted to further pursue, staff would certainly take that direction and run with it too. For example, access to serve, care or post-overdose response or peer support, some of those things that we talked about today, that if there were anything in particular, obviously all of them are evidence-based and need evaluation, and many of them are in motion already and would continue. But at least from a staff perspective, if there's anything that we're not doing that the board would like us to pursue, we would heed that direction.
All right, thank you, Mr. Manager. Gentlemen, we heard in Mr. Scalise's report all the things that this group has already been working on. We've seen the results of 2 of those items, but yet I also understand there were several other options in A that they were working on, and I would presume continue to work on and build further results from. Unless someone has specific items that you heard or saw in option A that you want more focus put on, I think my position would be let's ask the new director to focus on option A and all those options that are available, and continue to do the good work that they've done. But at the same time, as they develop more ideas and thoughts, bring that to us, and at the appropriate time, open option B for those things. Nettie, others, the panelists have any thoughts on that approach? I see a sort of head shaking, so I'm going to take that as some reasonable direction. So, gentlemen, any other thoughts? So, do I hear a motion that we direct the staff and new director to continue down option A with focuses on the things we've been working on and evaluation of all those things along with others in option A, and at whatever time might be appropriate, option B would be brought to the board for consideration. All those in favor of that approach signify by the uplifted hand. 5-0. Thank you, Madam Clerk, for that clarification. Now that will bring us, let me ask you to go to that page 3. I think it might be the most helpful place for us to begin through this opioid advisory committee. Madam Clerk, do we now have on this page all applicants that we have? Is that correct?
Yes, we do.
Okay. All right, so you'll see, gentlemen, that we have 11 spots to consider, one applicant for each spot. A number of applicants are available for a number of spots. So I think what I'm going to do first is ask us to consider seat number 1, seat number 4, and seat number 5, who for those seats only have one applicant or designee, that being the County Commission Chair designee, seat 1, Education Provider, seat 4, Dr. Welch, and a Payer Funder, LME MCO seat, Dr. Holden, seat number 5. So if I could have a motion to seat those folks in those 3 seats, since there are no more than one applicant for those seats.
Mr. Chairman, I'll make a motion.
Thank you, Mr. Stroud. All those in favor signify by the uplifted hand. That'd be 5-0. All right, that brings us to the second seat, healthcare providers and hospitals. We have 5 applicants for that seat: Dr. Seekert, Dr. Frank, Tina Stamey, Jesse Stout, and Dr. Woodward. And I would entertain nominations for seat number 2.
Mr. Chairman, I'd like to nominate Dr. Anthony Frank. My reasoning behind that is he is our county's medical director, and he also serves on the EMS peer review committee. All EMS workers and first responders in this county actually operate under his authority. So I would imagine he gets a wealth of knowledge about many of the issues that are going to be discussed.
Right. And am I correct? Did Dr. Frank, was he serving in the committee to start with? Was that someone? Yes. Yes. Okay. Any other nominees for seat number 2? All right, hearing none, we'll entertain a vote to seat Dr. Frank in seat number 2. All those in favor signify by the uplifted hand. 5-0. Seat number 3 is a seat representing social services providers. We have 3 applicants for that seat. Our DSS Director, Corey Fisher-Wellman. Corey does not live in the county, so we would need to accept or waive his residency requirement, which we can do if choose to seat him. Also have Katie Olson and Dr. Woodward. Do I hear any nominations for seat number 3?
Mr. Chairman, I'll make a motion, we appoint Dr. Woodward.
Motion for Dr. Woodward. Any other nominations for seat number 3? Seeing here none, all those in favor of seating Dr. Woodward indicate with uplifted hand. 5-0. Thank you very much. All right, that'll bring us to seat number 6. This seat represents law enforcement. We have Sheriff Heinzman, Captain Huffman, Dylan Smith, and Deputy Towery, who on his application indicated this was his second choice of a spot to fill on county appointments. So do I hear nominations for seat number 6?
Mr. Chairman, I'd like to nominate Sheriff Banks Heinzman.
Nomination for Sheriff Heinzman. Any other nominations for seat number 6? Seeing here none, all those in favor of Sheriff Heinzman indicate with uplifted hand. 5-0, Madam Clerk. Seat number 7 is a seat representing employers. We have 3 nominees there, but we have seated Dr. Woodward, who was able to, because of his status, could be considered in numerous locations, so he would not be currently considered for the seat number 7, since we've appointed him to seat number 3. Or I say him, I don't know Dr. Rivers Woodward. I guess it could be a female, but I don't know that. So, anyway, we have two, nominees, Jesse Stout and Katie Olson. Do I hear nominations for seat number 7?
Mr. Chairman, I would nominate Katie Olson to fill seat number 7.
Thank you, Commissioner Burns. Any other nominations for seat number 7? Seeing here none, all those in favor of seating Katie Olson indicate with the uplifted hand. 5-0. Seat number 8 represents community groups. This would be faith groups and other coalitions in the community. We have 4 applicants for that seat: Lonnie Brown, Georgia Lynn McWhorter, Karen Russell, and Tina Stamey. Do I hear nominations for seat number 8?
Mr. Chairman, as I'm certain that all of these are good, well, and qualified candidates, I have had an opportunity to have interactions with one of them several times over the past year, and every one of those interactions led to my understanding of this person's deep passion and connection to this issue. So at this time, I'd like to nominate Karen Russell for that seat.
Okay, Karen Russell. Do I hear other nominations for seat number 8? Seeing here none, all those in favor of seating Karen Russell for seat number 8 indicate by the uplifted hand. 5-0. Seat number 9, this is a lived experience seat. Have lots of applicants for that seat. Dawn Branch, Johnny Carswell, Jerry Duckworth, Brandy Greer, Georgia McWhorter, Katie Olson. We've just set Katie in seat 7, so we'll not consider that one. Randy Pritchard, Karen Russell, who we just set in seat 8. And then Tracy Stamey. So that leaves us 1, 2, 3, 4, 5, 6, 7 considerations for seat number 9. Do I hear nomination for seat number 9?
Mr. Chairman, I'd like to nominate Jerry Duckworth. I've spoken at length with him, and the fellow that recommended him was Judge Dan Kienert over the drug court. He has only the highest praise for Mr. Duckworth. In Mr. Duckworth's own words, I'm going to talk about him just for a second here, and he didn't mind me saying this at all, and he's proud of where he came from and where he's at now. He came from a good home. He's a local boy. He was a troubled youth. He's a graduate of Fruitland Bible College. He has tried many drugs, had a lot of his, I think he said 7 friends that overdosed. He was charged or convicted of attempted robbery. He accepted Jesus in jail, spent 7 months there. He's working presently on his Master's of Divinity. He teaches the youth group at Faith Presbyterian. He has a wife and 2 sons, and he's highly recommended by the judge on the drug court, Dan Kienert.
All right, thank you, Commissioner Smith. Other nominations for seat number 9? Seeing here none, all those in favor of seating Jerry Duckworth in seat number 9 indicate by the uplifted hand. It's 5-0. Which brings us to seat number 10. Again, we've already set Karen Russell, so that leaves Hannah Houston as a nominee for that seat.
Mr. Chairman, I make a motion to accept Hannah Houston's application for seat number 10.
Okay, thank you, Commissioner Burns. Those in favor of Hannah Houston, signify by the uplifted hand. 5-0. This brings us to the at-large seat, and many applicants can fit into that category. I'm not going to name them all. Just remember that we can't seat somebody we've already set earlier. A few of those are in this list as possible applicants. So with that, gentlemen, I'll open nominations for seat number 11, at-large seat.
Mr. Chairman, I'd like to Johnny Carswell on seat number 11.
Okay, we have a nomination for Carswell on seat number 11. Any other nominations for seat number 11?
Mr. Chairman, I'd like to nominate Brandy Greer.
Randy Greer for seat number 11. Any other nominations? Hearing none, I'll entertain a vote for those in favor of Mr. Carswell for seat number 11, signify by the uplifted hand. That's 4. Those in favor of Randy Greer, 1. Okay. That'll seat Johnny Carswell in seat number 11. Okay. That concludes the makeup of our opioid advisory committee. Let me thank all of those folks who were interested and applied for this committee. Very important work ahead. And I certainly want to thank everyone for the work in the past. Commend our task force up to this point. Great work has been accomplished. Good things have been done, and we certainly look forward to a lot of great work and good work coming into the future. So we have concluded our items for decision. Help me out, Madam Clerk, if I'm about to miss something.
I think we're ready for number 5, adjournment.
Number 5, the one we have been working toward all morning. Again, I want to thank the board and all of you for taking time out to be here this morning. Very important work. We've heard the passion in the room for the work and for those families and those loved ones and everybody around us. I don't think there's anybody in this room could say that they have in some way, some form been impacted by opioid use and its destructive things that can happen because of it, even in the face of understanding that perhaps there are some good things out of opioids that we use and continue to have to use on a daily basis in some areas, but at the same time has led to great destruction in our community. And we've seen through the slides this morning, particularly the slide that showed the amount of dollars that came to Burke County, and that was simply because there was tremendous damage in Burke County because of prescription drugs and other things that we have lived with as we have heard about today. Again, thank you for being here. Gentlemen, I'll entertain a motion to adjourn at this time.
Mr. Chairman, could I just make a quick comment? Yes. I spent a considerable amount of time on the applications, and I really would like for everybody to have been included in the board. I hope at some point we'll even expand that board. It's such an important topic. We've got a lot of community members that are adversely affected. Myself, 3 siblings I've lost through substance use. So we've all in this room felt the pain or work in that area and see the pain. I hope this group, this board, will meet frequently. I hope we won't delay. I hope we don't have analysis to paralysis. It's urgent. We all know it's urgent. But I hope you'll meet frequently and you'll communicate often and we'll take action quickly. And it was never a vote against anybody. Again, I would like to see every single person that put the application in part of this board. And perhaps in the future that can be expanded so more people in the community have a voice. And with that, Mr. Chairman, I'll make a motion to adjourn.
Thank you, Mr. Barrier. All those in favor signify by the uplifted hand. And Madam Clerk, that's 5-0.